All right, thank you, Jane. Good morning, everybody. It's so wonderful to be here. My name is Dr. Cheryl Green, and I'm a clinical and health psychologist at the Women's Health Concerns Clinic at St. Joseph's Healthcare here in Hamilton. And I'm also an associate professor in the Department of Psychiatry at McMaster University. We're going to begin by having us all take part in the land acknowledgement. So we would like to take this time to give honor and thanks to the Haudenosaunee and Anishinaabe nations as the traditional inhabitants of the lands that surround us. To say that is to acknowledge a debt to those who were here before us and to recognize our responsibilities as guests to respect and honor the intimate relationship Indigenous peoples have to the land.
Thank you, Cheryl. Hi, everybody. I'm Luisa Caropreso. I'm a psychiatrist at the Women's Health Concerns Clinic, and I am also an assistant professor at McMaster University. So we gather today in support of women, people assigned female at birth, families, workplaces, and communities, in the spirit of supporting all of us towards mental wellness and bringing light into the conversation on the complex interplay of psychosocial, genetic, and biological factors such as hormones and their impact on perinatal mental health.
Thank you, Luisa. So I want to also echo my colleagues and welcome everyone from across the world that have logged in to participate in this opening up event. I'm Dr. Benicio Fry. I'm a psychiatrist and a former medical director of the Women's Health Concerns Clinic here at St. Joe's. I have the privilege of working with Dr. Green and Dr. Caropreso here every day. I want to say that I'm so happy and thrilled with the dream team of 6 amazing speakers that we have here for all of you to enjoy and ask them questions. A little bit about this opening up event. This is our 4th event, so we've been doing this event for over 4 years now. I want to really share with you the vision of this event. It's been done in collaboration between our Women's Health Concerns Clinic team and also the Women's Health Concerns Clinic Community Advisory Committee. We have a wonderful committee with people with lived experience, pharmacists, psychotherapists, trainees that give us advice on how to best use our resources for research and educational purposes. And about 5-6 years ago or so, the Women's Health Concerns Clinic was selected by Shoppers Drug Mart to be the recipient of their unrestricted fund for education and research. Every year, Shoppers Drug Mart promotes a run for women every summer, and we have been then using part of this gift to run a public event, which is called Opening Up. So I'm really, really grateful. I want to thank Shoppers Drug Mart Run for Women for supporting this event, and also our Community Advisory Committee for helping us organizing, the vision for this event. So really, this is an opportunity for each of you to interact with these amazing presenters. You can use the Q&A box, down at the bottom of your Zoom to send us any questions that you may have for any of the speakers. So I encourage everyone to be active in this, information exchange. I also want to just some housekeeping information. So this is a webinar format. So you're only going to see the speakers, and then we're going to have a series of presentations, and we will make sure that at the end we're going to have time to answer the as many questions as we can answer from the audience. So please feel free to be active. With that, I would like to welcome Dr. Green back. Thank you very much and enjoy the event.
Thank you so much, Dr. Fry. So I do want to just acknowledge that we will be dealing openly and candidly about some things that might be triggering for some of our viewers or participants. So we really encourage you to listen with care, please. We are going to do a little activity here before we begin, and that is an online poll. So I know that our event coordinators, Jane and Emily, they're going to start with this poll to let us know. We hope to have you let us know where you're joining us from today. In previous meetings, we have had people from all over Canada, all over North America, and as far as Australia. So we're super interested in learning where you're coming from here and joining us today. So just take a moment and complete that online poll. And that's our goal, really, right? To be able to reach as many people as possible with events like this. So hoping to have you participate, and I believe we will learn maybe the results. Maybe Jane and Emily will direct me as to if that's a little bit later today or now. I'm not very technically inclined with that. I don't know how quickly that can get summarized, but maybe we'll leave that for the results for a little bit later today.
No, we can share now, Cheryl, I think.
We can? Okay. Where might I find that?
Oh, you relax. And
Okay.
Emily, I think, is just going to share results, and or I can, Emily. I feel as if the Jeopardy song should be playing at this moment.
It does.
Okay.
We'll have that for future opening up events.
So we'll get those shortly. They're just being collated now. So sit tight and we'll get back to you on that. Thanks so much, Cheryl.
Okay, thank you, Jane. All right, well, we will move on here, and I get the pleasure and privilege here of being able to introduce our first speaker, and that is Dr. Daisy Singla. So Dr. Singla is a clinical psychologist, a senior scientist at the Center for Addiction and Mental Health, and she's also an associate professor in the Department of Psychiatry at the University of Toronto. Dr. Singla aspires to increase access to evidence-based psychological treatments in order to enrich the lives of all women, their children, and their families. Her presentation today has to do with talk therapies, which are amongst the most effective treatments in mental health care, but remain largely inaccessible. The Summit trial explored scalable innovations, to enhance access to talk therapies for depression and anxiety in both pregnant and postpartum populations. Please welcome Dr. Singla.
Okay, thank you so much, Cheryl. It's terrific to be here. And it's a real honor to be here with all of you to speak about a topic that I think we all care about, which is perinatal mental health. As Dr. Green mentioned, I'm a clinical psychologist, and I've had the pleasure of working with NGOs and organizations around the world, really with one goal in mind, and that's to improve access to talk therapies, which we know, as Dr. Green mentioned, are amongst the most effective interventions that we have for extremely common conditions like depression, anxiety, and stress-related disorders. But before I get there, before I talk about my research, I'm going to talk a little bit about the stats and how common these conditions are in pregnant and postpartum women, not just here at home, but really globally. So around the world, the stats say that 1 in every 5 individuals, perinatal individuals, referring to pregnant and postpartum individuals, experience depression and anxiety during pregnancy and all the way up to 1 year postpartum. And of course, we are no exception here in Canada. In fact, some would argue that these stats are an underestimate. And it's actually 1 in 4 individuals, pregnant and postpartum people, affected by perinatal mental health issues. So you can imagine that if we have 400,000 births in Canada per year, around 100,000 individuals are affected by these extremely common conditions at any given time. We also know that conditions like depression and anxiety are actually amongst the most common complications that occur during this period. In fact, they're more common than things like gestational diabetes, preeclampsia, and other pregnancy-related health problems. And while depression and anxiety is arguably the most studied condition in perinatal mental health, there's also a lot of other serious problems that individuals encounter, such as perinatal mania, as well as psychosis. And I can answer any questions related to that. During the perinatal period, which, as I said, is when an individual becomes pregnant all the way up to 1 year postpartum, actually the highest risk period is when they have delivered and when their child becomes an infant. And that's something to keep in mind as I share some of the research ahead. The other thing to keep in mind with perinatal mental health is that it's not just a problem that one encounters alone. We know that we know from many, many studies that have been conducted, actually almost 75 at this point, that depression in fathers is very common. Not as common, but the rates say about 1 in 10. And it's very common that if one person is experiencing perinatal mental health challenges, the other is at much higher risk, speaking to the fact that really this is often experienced by both partners in a relationship. In terms of risk factors, there's a whole host of risk factors, from a personal history to a family history. But what I really want to highlight here is inadequate social support. So as I mentioned, I've worked in some of the most rural areas of sub-Saharan Africa and South Asia. And what we notice around the world is, regardless of how one describes their symptoms or how one experiences their symptoms, we know that social support is a key risk factor, or a lack of social support is a key risk factor or protective factor in not just the development of things like perinatal depression and anxiety, but also its persistence. And so one of the things that we really try to highlight in talk therapies, in our effective interventions, is improving aspects of social support, if not between the individual and their partner, the individual and their child, but also with their larger support network, most importantly. Of course, there are a lot of consequences, and we know the consequences are intergenerational, having effects on the individual's daily function, their child, and more recently, we know that suicide is one of the leading causes of maternal mortality in Canada, but also around the world. I promise I'll get to the more positive stuff in just a moment, but simply to say that what we know is that we have extremely effective interventions for common conditions such as depression and anxiety, which I'll be speaking about in just a moment. And access is a real problem. And there's many reasons for why individuals can't access treatment. And really, my work is focused on improving access to these talk therapies, regardless of where someone lives or their background. So I'm going to switch gears to talk therapies, and you'll see in this presentation that I use lots of terms to describe this. Amongst them are psychological interventions. You'll hear me use the word psychological treatments, but what I'm really getting to is brief psychological talk therapies. And what that basically means, some of you may have heard of cognitive behavioral therapy, you might have heard of interpersonal psychotherapy, you might have heard of behavioral activation. These are brief interventions focused on improving one's mood by improving their relationships, their behaviors, and modifying their thoughts, in a nutshell. And remarkably, despite that brief description, they are extremely effective and recommended as the first-line treatment to address this enormous burden of depression, anxiety, and stress-related disorders, both globally, but also in our local context here in Canada. So in high-income countries, for example, in Canada, and as I just mentioned, 1 in 5 individuals may have access to these effective interventions. And the irony is that not only are they effective, but they're actually preferred by most pregnant patients. So the wide majority, and I'm sure many of you can relate, would prefer to engage in individual talk therapy rather than taking medications. And yet we know that there are many, many common barriers to accessing these effective interventions. For example, the cost to see a psychologist, particularly a private psychologist or a psychiatrist, accessing this specialist care can often be a nightmare for individuals, not least when they're experiencing a whole host of challenging symptoms. Navigating our healthcare system is no small feat. And particularly for pregnant and postpartum individuals, arranging transportation or childcare is an added challenge. So the good news is that we have extremely effective interventions, and we have ways, and we can study ways that we know can improve access to these effective talk therapies. So the first solution that I'm going to talk about is task sharing. And according to the World Health Organization, effectively, this means training individuals who are not specialists to deliver these effective interventions. And this is really what I've spent a good chunk of my career doing. The second solution is telemedicine, which may feel a bit passé, and I'll explain a little more as to why I'm focusing on telemedicine and evaluating it as one solution. And as you may have experienced yourself, telemedicine has really revolutionized how we offer treatments, both in terms of making this much more patient-centered, improving access, but also in removing key barriers related to scheduling, childcare, and transportation. So let me start off with task sharing, which can be a mouthful, but I'm going to use it because that's the term that we typically use as researchers, but also as clinicians. And what I find remarkable is, regardless of the country in which I'm working, is this is not just something that we are doing. Individuals around the world, groups around the world, have trained an extraordinary and diverse number of groups to actually deliver these evidence-based talk therapies. So these are individuals who have no specialized professional clinical training in mental health. And it really depends on the context in which you're working. So we use large-scale studies to demonstrate whether individuals can actually implement these treatments effectively for common conditions such as such as depression and anxiety. And we know that a whole range of individuals, whether it's nurses or midwives or teachers or community healthcare workers, or peers or health volunteers, have been shown to deliver these interventions quite effectively. The question that I used to get, particularly in low and middle income countries, is whether these interventions actually work. It's one thing to train individuals, it's another thing to watch whether they can implement it. But the real proof of the pudding is to conduct large research studies and compare whether individuals who receive treatment from these non-specialist providers actually get better. And indeed, what this shows is that they do get better. And in fact, this is quite comparable to specialist delivered treatments. And so we sought out to conduct another review, but not focused on low and middle income countries, but this time focused on high income countries, to see whether non-specialists, again, individuals with no formal or specialized training in or degree in mental health care could deliver these interventions, these brief psychological therapies effectively. And indeed, again, we found that these individuals could. And remarkably, we identified 45 randomized control trials just focused on depression and anxiety and stress-related disorders. in the perinatal population. Another solution that I mentioned is telemedicine. And interestingly, prior to the pandemic, most studies evaluating telemedicine platforms were small, and which means that we couldn't draw too many conclusions about them in terms of their comparable effectiveness to in-person psychotherapy. And so my colleagues and I, including Dr. Simone Bigot, who you'll be hearing from in a little bit later on, sought out to implement the SUMMIT trial. And the SUMMIT trial stands for Scaling Up Maternal Mental Health Care by Increasing Access to Treatment. That's a mouthful, so I'm just going to refer to this as SUMMIT. And we really sought out to answer two key questions. And that was, can a brief psychotherapy delivered via telemedicine, is that as effective as in-person psychotherapy? And secondly, can non-specialist providers, in this case, nurses, midwives, and doulas, deliver a brief psychotherapy as effectively as specialist providers, such as psychiatrists, psychologists, and social workers? In the research world, we refer to this as a non-inferiority trial, because we're really trying to look at, is something as good as the gold standard treatment in this case being in-person care, as well as care delivered by specialists. And so we recruited adult, pregnant, and postpartum patients from Toronto, Chapel Hill, and Chicago, and we randomized them to receive one of these 4 conditions. And everyone received the same 8-session behavioral activation treatment, which I'll get to in just a moment as to what that is. As mentioned, patients were recruited across 3 cities, Toronto, Chapel Hill, and Chicago. In Toronto, we focused primarily on recruiting patients from Mount Sinai Hospital, Women's College Hospital, led by Dr. Bigot, and St. Mike's. And we also had partners in Chicago and Chapel Hill. These are the principal investigators of the study. And what's remarkable about this team is not just the researchers that are contributing to this study, but most importantly, the interdisciplinary perspective. So as mentioned, I'm a clinical psychologist and global mental health researcher. Both Dr. Bigot and Dr. Meltzer Brody are perinatal psychiatrists. Dr. Richard Silver is a maternal fetal specialist or obstetrician. And Dr. Cindy Lee Dennis is a nurse by training and also an epidemiologist. So that speaks to the fact that perinatal mental health is not the domain of one given discipline. It really spreads across many, many disciplines. And most importantly, not just academic disciplines, but we've had the pleasure of partnering with many individuals with lived experience, patient advocates, and a whole number of diverse community-based and healthcare-based clinicians and researchers to inform not just the development of this trial, but most importantly, equally importantly, the implementation and now the dissemination of the study. Again, having diverse voices at the table has really brought not just diverse perspectives, but really enhanced, in my opinion, the breadth and the depth of this study. So I promised that I would describe the treatment in detail. And for those of you who may be clinicians, our 8-session manual is available for free on our Summit trial website. And the intervention that we offered was relatively brief. So 6 to 8 sessions delivered on a weekly basis, again, by a non-specialist or specialist provider. Everyone received the same training, everyone received the same treatment. And the reason we chose this particular treatment was really threefold. It has a strong evidence base. It's effective in treating the conditions of interest, in this case, depression and anxiety in pregnant and postpartum patients. And it's easy to learn, as demonstrated by many task-sharing trials that have been conducted around the world. And in fact, this manual was adapted from an effective intervention that was developed in India and effectively delivered by non-specialist providers or lay counselors in India. And so it's an important example of reverse engineering as well. In terms of our trial progress, I'm excited to share with you all that we saw really high client satisfaction rates. So across the patients who received at least one session, which is the wide majority of participants in our trial, 93% of individuals received one or more sessions. They said that their experience, their overall satisfaction was rated between mostly satisfied and very satisfied. And this is really important because it's not enough just to assess whether someone's symptoms are improving. It also matters whether they like what they're getting, because we know that that's an important predictor for whether they stay in treatment. We also have a huge emphasis on a patient-centered approach, and I'm happy to speak about that in more detail in just a moment. When we asked individuals what did they like or what would they like to change, individuals, the patients reported that they liked the empathy that their provider showed. And they also liked the behavioral activation, the treatment tools and activities. When we asked individuals what would they like to change or what did they not like, they said that they would have liked to have more sessions. And this has really been my experience, both as a clinician and as a researcher around the world. Typically, individuals want more of what they want more of what they like, or they wouldn't have changed anything at all. So this is what we would call a psychotherapy trial, and psychotherapy trials are notorious for not offering treatment to ethnically diverse patients. So we're really proud that thanks to our partnerships with the community and our expansive referral networks, we were able to identify almost 50% of individuals identified as Black, Indigenous, or persons of color. And we saw really high retention rates from a data perspective at our follow-up rates at 3, 6, and 12 months post-randomization. And these numbers are hot off the press. And so we just were able to look at our 12-month data. We still have 3 more participants to receive data from. But what you can see here in this graph is that individuals come in with pretty high levels of symptoms of depression, moderate levels of symptoms, and they go down to effectively minimal symptoms. So while I can't show the comparisons between the two groups, I think that I think you can see from the graph that across the entire group, participants' symptoms reported that they went down quite significantly from moderate symptoms all the way to minimal symptoms in terms of their depression. And similarly with their anxiety symptoms. So individuals came in with moderate levels of, on average, individuals came in with moderate levels of symptoms, and they went down to quite mild levels of symptoms of anxiety at 12, and this was sustained. So the treatment ended somewhere around here. This was sustained at 3 months, 6 months, and 12 months post-randomization. We have an entire separate component of interviewing, so and collecting what we call qualitative interviews from a diverse group of individuals. As mentioned, Women's College is a key partner in this study, and so we interview individuals who have received the treatment, individuals who have delivered the treatment, so the providers, as well as partners. And overall, the response has been quite positive. And again, I think this speaks to the importance of collaborating with communities in implementing these large-scale interventions. In terms of next steps, we are continuing to collect data from our wonderful participants. So as I mentioned, we have 3 more participants to collect data from, and we hope to complete this 5-year endeavor on February the 13th. We also have an entirely separate component of home visits in which we're not just assessing the outcomes of the mother, but also those of the child, to look at the relationship between maternal mental health along with child development. We are conducting testimonials, and I will share one video with you, which is hot off the press. I just received it this morning, and I'm excited to share that with you if it works. And the question that I get from policymakers and for those who are decision makers is, how much is this going to cost and how much is this going to save? And so we have applied and are currently conducting a cost evaluation to examine that precise question. So in sum, and if I have time, I will show a video. The Summit trial really does demonstrate the promise of task sharing and telemedicine to improve access to these brief and extremely effective talk therapies, which of course are one solution of many in the paradigm of perinatal mental health, but of course an extremely effective solution for common conditions like depression and anxiety. We are proud to say that we conducted this study in very diverse geographical locations, offering this treatment to extremely diverse patients. You know, we've really been guided by a patient-centered and stakeholder-informed approach. And we also boast that this is amongst the largest psychotherapy trials in the world, in which we had the pleasure of serving over 1,200 patients over the last 5 years. So I think I'm going to have to stop sharing and re-share in order for you guys to see the video. So please bear with me.
In the Summit study, we aim to improve access to talk therapies for perinatal individuals experiencing depression and anxiety through two solutions. First, by offering telemedicine, where people could attend talk therapy virtually, and second, by training healthcare providers like nurses, midwives, and doulas to deliver these effective interventions.
Complications related to mental health in and around pregnancy leads to the highest rate of mortality.
We know from the research that the majority of perinatal women and other people prefer psychotherapy or talk therapy as the first-line treatment if they have anxiety or depression during the perinatal period.
Behavioral activation is a brief, structured psychotherapy with a huge evidentiary base as an effective depression treatment.
I usually work more with CBT, which for me, behavior activation was something new. But I think that help the patient to, in a short period of time, to see how they can impact their mood by just identifying activities that they can do, that they can enjoy, and reconnect with the joy that they had in the past with certain activities.
Some benefits that I noticed my patients experiencing by participating in Summit were decreased isolation, increased acknowledgement or recognition of the things that they do in their life that really help them with their mood.
I have seen a handful of therapists in the past, and it honestly felt no different to me to have a nurse as a provider. My provider seemed motivated to help me, always listened to me, and was really engaged in the process.
Nurses, they make really good candidates for delivering behavioral activation. They are used to helping patients at a very vulnerable time.
The challenge or new aspect, which was providing therapy, something that I'd never done before or thought I never did. I came to realize that there were some parts of what I did as a nurse that I was able to use in this study.
Our goal is not to replace specialist providers, but we're very aware of the fact that there has been an increased burden on specialist providers to deliver care, which is why there's such long wait lists. There just isn't enough psychotherapists and psychiatrists and psychologists to meet the needs of patients.
To me, it's a matter of equity and advocacy. So we have the solution of evidence-based psychological treatments. We also have a lot of women, pregnant and postpartum, who are suffering from the burden of depression and anxiety. So to put the two together, to optimize ways to find evidence-based solutions for these pregnant and postpartum women to improve their mental health care seemed like a no-brainer.
Great. I hope that was that you could hear that and see that, but I'll stop there. Thank you so much.
All right, I want to thank Dr. Singla so very much for providing just a wonderful presentation, delivering so much information and education to us all. A few things that stood out to me that this never ceases to shock me is just the prevalence of mental health difficulties. 1 in 5 women and birthing people experiencing depression, anxiety, and maybe even more than that. The fact that this is a family affair, so acknowledging that it's not just the woman and birthing person who's affected, it's 1 in 10 people who are partners, 1 in 10 fathers can also, and other partners can experience mental health difficulties. The fact that there is effective treatments out there, which is wonderful, but that they are inaccessible is such a challenge. And knowing that women and birthing people do prefer to engage in psychotherapy, a non-pharmacological treatment option, supposed medications to be treated for their mental health difficulties is so important. And so highlighting maybe what the solutions can be with task sharing and telemedicine, and seeing how encouraging the outcomes from the Summit trial are, Dr. Singler, they're amazing. And certainly in our own clinic here, the Women's Health Concerns Clinic at St. Joe's, this is the reality. There's one psychologist, that's myself, and we have a wonderful team of multidisciplinary team members, a lot of RNs and social workers. And so these are the individuals who are also administering psychotherapy and in a very effective and evidence-based way. And so the results of your study are very consistent what we do and see in our clinic, in continuing to deliver virtual treatment in a very evidence-based and effective way as well. So it's nice to see that consistency with what we're doing here is consistent with your results. And one last thing that just stood out to me was that you not only evaluated the effectiveness of the treatments from a symptom measure, but highlighted how important it is to have individuals receive the treatment well. So that high satisfaction with treatment is so important. So thank you for capturing and highlighting that. Once again, thank you for a wonderful presentation. We're going to meet our next presenter here now, and this is one of our individuals, people with lived experience. I'd have the, again, pleasure and privilege to introduce Christine. So Christine is a former educator and passionate advocate for mental health. She lives with mental health conditions, and she is also the mom of 3 beautiful children, including a set of twins. So no downtime there, right, Christine? In her work, home, and personal life, Christine is open about her own mental health in times of mental illness, hoping that others will not suffer alone, and raising awareness that better is possible. Warm welcome to you, Christine.
Hi, thanks, Dr. Green. Yeah, my name is Christine. I'm someone who has gone through postpartum depression and anxiety, as well as having a previous diagnosis of generalized anxiety and borderline personality disorder, or BPD is what I'll refer it to. Back in 2012, I was diagnosed with generalized anxiety, and this diagnosis should have been made probably when I was a kid. In 2014, I had a mental breakdown after teaching for 1 year, and from there it was determined that I struggled with BPD. I had suffered the effects of bullying in my teen years, which in turn led me to have very poor coping mechanisms, impulsive behavior, and intense emotions that I didn't know how to handle. After going through dialectical behavioral therapy, which is also referred to as DBT, for BPD, and doing cognitive behavioral therapy for generalized anxiety, my husband and I were able to confidently start trying for our first child. It was very nerve-wracking, something that I wasn't sure I was going to be able to handle, since I still struggled with anxiety and was kind of fresh out of getting help for borderline. Thankfully, I was able to make an appointment with the Women's Health Concern Clinic here in Hamilton, Ontario. And I was able to talk about the different medications I was taking and whether or not they would be harmful to me or baby if I was to get pregnant. This appointment was so vital to making me feel ready. I was told that I could stay on my medications. It posed no risk to me or my baby. And really the only side effect that might happen would be withdrawal from, like, the baby will have withdrawal from the medications I was taking. But other than that, that was like very minimal. We got pregnant with our son in 2018. And I quickly self-referred to the Women's Health Concern Clinic here in Hamilton to make sure that I had the resources on hand for what was to come. I also had an amazing team of midwives, which I actually thoroughly searched out. My primary midwife had a degree in psychology, and after meeting with her, felt she would be a good fit for my perinatal mental health journey. My previous diagnosis of BPD made me very nervous that I would actually relapse after giving birth. So after my son Leo was born, my anxiety did spike, and I was a very anxious first-time mom. I slept in the living room on the couch. My husband slept on the floor, and baby in the bassinet. And I worked with one of the psychiatrists and clinicians at the clinic, at the Women's Health Concern Clinic, and also was enrolled in the postpartum anxiety therapy that they have. I worked with my clinician and psychiatrist. My clinician was a nurse and a psychiatrist through the first year of motherhood, and it helped me become a more confident mom. There were times I could see myself slipping into old coping mechanisms and some pretty intense emotions that I had as, you know, I grew as a mom. But thankfully, with the therapy I had done for BPD and for my anxiety, I had the tools in my toolbox to be able to work through them properly and didn't have a full relapse. Fast forward to 2022, when we got pregnant for a second time. After finding out we were pregnant, I again self-referred to the Women's Health Concern Clinic in Hamilton. I had the same midwives lined up, knowing I was well taken care of through my first pregnancy and postpartum. Then kind of a twist happened. We got COVID, and I had some spotting at 7 weeks. So I was pretty anxious, and I found myself in urgent care, double masked, by myself, getting a ultrasound. There I found out, again, by myself, not with my husband. My husband was outside with my son, that I was pregnant with twins. And at that point, I actually was told that they were what was called mono twins, which is where they share the same placenta and same amniotic sac. So we were absolutely terrified. A few months with debilitating anxiety because we had to wait before we got seen at McMaster. We finally had our appointment at MAC at the High Risk Maternal Fetal Medicine Clinic. There we found out that they were actually only sharing the placenta and not the amniotic sac. And the ultrasound apparently at the urgent care was very, very grainy. And so they couldn't see the split. So again, we were very thankful for this news, as it was still high risk. I would still be seen every 2 weeks, but it wasn't nearly as high risk as what they call mono twins. So since the wait times at the Women's Health Concern Clinic were quite long because of the pandemic, I didn't get in until about 2 weeks before the twins were born. I was able to meet the team I would work with and felt enough reassurance that I had the right people in my corner. Our twins, Quinn and Maeve, were born via planned C-section, all going well after a relatively smooth twin pregnancy. However, during, again, another twist, during the first night, one of the twins wasn't eating very well. And so we were kind of trying to figure out, like, does she have a tongue tie? Like, is something else wrong? And sure enough, she had a cleft soft palate that they didn't find when she was born. So she was whisked to the NICU where she was taken care of, fed via like a new feeding system. And I was left with my other twin, Quinn, freshly postpartum, like freshly out of a C-section, not able to get up. I didn't even know where the NICU was at this point. So yeah, the emotions that were going on in me were like very intense, and I was quite tired and distraught. The nurses in the postpartum unit were so amazing. They took my daughter Quinn while we went to go feed Maeve, and thankfully, we were all discharged together. So Maeve got discharged from the NICU, and then we brought her back to the postpartum unit where we all got discharged together. Maeve had a special feeding plan. She just had to feed with a special bottle, and then she would have a surgery at 1 year. So all this happened. My husband couldn't take a lot of time off work. He just started a new job. So this was, again, another loop that we were thrown into. My mom took 3 months off and came every day. And then we had people from my church, family, friends come in the afternoon and evenings to help with the twins and then our then 4-year-old. I knew I had my clinician and psychiatrist at the Women's Health Concern Clinic. We had a village, and for that we are so thankful. The postpartum anxiety this time around hit really hard. Then at 2 months old, the twins contracted RSV. Maeve, the one with the cleft palate, was actually having a really hard time. So I brought her into the hospital, and she ended up in the pediatric ICU and was very sick for 7 days. Quinn never got sick, thank goodness, but my mental health took a turn for the worst. A few weeks after we all got home again, I became very withdrawn and isolated. I didn't want to get out of bed or shower. I kept telling myself that I was going to hit that 12-week mark, the 3-month mark, and everything was going to be magically better. It wasn't. My therapist actually just came off of mat leave as well at that time, and she saw me for the first time during this period, and she hadn't met me before, but at the same time was like, something's really off with her. Like, I've never met her, but this doesn't sound like what the psychiatrist was saying about me. She was very worried, alerted my psychiatrist at the time. And as I was already working through cognitive behavioral therapy for postpartum anxiety, that was helping the anxiety, but she also wanted me to work on the postpartum depression CBT as well. So we decided to get me into that group. The therapy was helping. I was getting out of bed. I was taking care of the twins, but I was kind of at that point just going through the motions. I had no life in my eyes. I didn't interact with the babies. I kind of just did what I needed to do to survive. I had 3 young kids at home and really no enjoyment. After a few different medications, we found something that worked with my current medication, because of course I stayed on my meds throughout my whole pregnancy, throughout the postpartum period, and we were able to find something that worked well with my current medication. Once my meds were figured out, the fog was lifting, and as the fog lifted, the anxiety came back at full force. So we worked through it with one-on-one therapy, as I had already done the CBT for anxiety. And then as time went on, the anxiety did subside and things were going relatively well. I am so grateful for the team at Women's Health Concern Clinic. I found joy in my life again. I am sad that I wasn't able to enjoy my little babies, but I am so thankful that I am actually still here to talk about it and share my story of hope with others. Also, to kind of tagline, I was able to participate in a peer support group through my first year postpartum, and this was so amazing, being able to talk to other moms that were going through the exact same things as me. Maybe a little different. Obviously, everybody's going to react differently to being postpartum, but it was nice to talk with a group of women that knew what life was like at this point. I actually met a few twin moms through that, which was amazing. Today, I still feel the effects of postpartum depression. It's been 2 years. The twins turned 2 in November. But when I was in the thick of postpartum depression, I became a very angry person. I'm still dealing with what they call mom rage, and still trying to figure out the enjoyment outside of my kids' lives. So, like finding things for myself. I'm still in therapy, just trying to work through these crazy years of having very young kids. Between my first and second pregnancy, I actually was a runner, and it was a very big passion of mine. Since having the twins, this passion hasn't come back, but I am slowly working towards getting back into running, and I'm giving myself a lot of grace. If there is anything I want you to take from this story, it's that there really is hope. There are so many amazing doctors, midwives, therapists, nurses out there willing to help us through the trenches. Thank you.
Thank you so much for sharing your story with us, Christine. And stories like this are why we wanted to present the Opening Up Forum, like with people who lived through it, right? For people to know the real life impact, right? And I commend you, Christine, for like reaching out for like all of the supports you could, right? So you did the like DBT and CBT, which are like first line treatments, right? And you came for a consultation before pregnancy to ask about your medications, and that's so important because we see that so many people just stop the medication cold turkey while it's a medication they could take and maybe need it, right? And also you reach out to, like, you built a village, right? So you ask for help like from church, family, friends, and we see that for so many women it's so hard to ask for help, right? A lot of women have the thoughts that they are supposed to do everything by themselves, and that asking for help is a sign of weakness, but it's not. It's a sign of strength, right? And I'm so glad that you were also able to reach out to like a peer support, right? To talk to other women who are experiencing similar things. So thank you so much for sharing your story, Christine. And next, I'd like to introduce Dr. Tomfer-Madsen. Dr. Leanne Tomfer-Madsen is an associate professor in the Faculty of Education at the University of British Columbia and the Canada Research Chair in Mental Health Equity. Her current program of research has been profoundly influenced her role as a mother and her clinical work, which has often led her to engage in community building, mindfulness, and self-compassion research. Leanne's starting point was to consider that when experiencing perinatal mental health problems, people often worry about the risk of transmitting depression and anxiety to their children. The Building Emotional Awareness and Mental Health, or BEAM, program was designed to reduce feelings of depression, anxiety, and anger in parents, while also building parenting skills that help prevent the intergenerational transmission of risk. Dr. Tomfer-Madsen.
Thank you, everyone. Thanks for having me. Christine, I'm still teary at the thought of your kids going into the hospital with RSV. Just that moment that you shared really got me. So I just want to thank you so much for sharing your story and being so vulnerable and open with us. I'm going to talk a little bit about mom rage. I'm really glad that you brought it up because I think that we don't talk about it enough. Um, I'm going to try and share my screen here. So I am going to talk to you today about the BEAM program, and I'm actually going to tell you a lot of stories. Um, the BEAM program stands for Building Emotional Awareness and Mental Health for Families in the Early Years. And we've been working on this for the last 5 years or so since the beginning of the pandemic. We've really been trying to create a program that supports families from conception to kindergarten, which is what we conceptualize pregnancy and the postpartum to be. We see that when folks have perinatal mental health problems, they're often present when they're pregnant, and they exist for a long time. And so our goal with BEAM is to provide this comprehensive support. I'll tell you a little bit about how BEAM started. So pre-pandemic, myself and my very good friend and collaborator, Dr. Leslie Roos, were developing programs that responded to a need for family mental health programming. So I was really focusing on this interruption of the intergenerational transmission of stress. So from pregnant person to their baby, and Leslie was working on this work to provide mental health programming for parents of young children. And we were both developing these emotion-focused mental health programs, her more focused on parenting, for people who were managing depression and co-occurring conditions, so things like anxiety and PTSD. And then at the beginning of the pandemic, probably around April of 2020, we both launched these 2 large epidemiological cohort studies, which just means we started recruiting as many people as we could to ask how they were doing during the pandemic. So the study I run is called Pregnancy During the Pandemic, and hers was called Parenting During the Pandemic. And we just saw these enormous increases in mental health problems, like truly, truly terrifying, where in early stages of the pandemic, people who were pregnant, like 40 to 50% of people were reporting elevations in their feelings of depression and their feelings of anxiety. We saw the same with parents, particularly parents who were home with their little kids. We also saw quite large increases in anger. So during that time, Leslie, who I didn't actually know that well, we'd been to a couple of conferences together, called me into a Zoom room. And she said, we need to do something. And she's like, we need to do something really, really fast for these parents. And so we applied for a really quick grant to develop an app of us sharing mental health material. And then we started running groups with people so that we would share out the mental health material. They would watch the stuff in advance, and then they'd meet with us in groups from all over Alberta and Manitoba. And we co-developed all of this with our advisory board. So we have a number of people with lived experience who were coming in and talking to us about what they wanted and what they needed during that time, which was really like a lot of support with emotional regulation, but also people were so lonely. And so we would just get together and we would talk about the fact that people were struggling. They were by themselves in their house with their kids, which is enough to make anybody feel a little bit unhinged, but particularly if you've already been experiencing symptoms of mental illness. We developed a really bad app in the beginning. Anybody who's done this kind of app-based work knows that this isn't an easy process, but we still managed to have pretty good effects of BEAM. And so we have been running this project now for 5 years. We've done 6 randomized control trials, and we've adopted this approach from tech, which is called like fail fast rapid iteration. So we have not done one trial of BEAM that's exactly like the last. Every time we do a trial, we go back to the drawing board, we meet with our patient advisory board, we interview people who've been through the program, and we do a little bit of an adaptation. So now we're doing an implementation trial of our current study. We've got about 400 people in Manitoba and 200 in BC and Alberta who are participating. And what we've really landed on is this idea that parents want to do a treatment. I'm actually going to show you a video. Parents want to do treatment that is tailored to their time restrictions. What they have going on in their life is often like 15-minute little snippets. They have told us that they want to be interacting with peer support workers with the support of psychologists. So BEAM is delivered at this point largely by people who are peers, people who've had lived experience of depression, anxiety, and are in recovery. And they share this information about getting back to your mental health, getting back mental health and reclaiming joy. And they also share evidence-based parenting techniques. So I'm actually going to show you the video that we've made here. If anybody has trouble with the sound, please let me know, because this is our peer coach who's gone through the treatment, explaining it, and then the people who are on the ground delivering it.
5 years ago, parenting didn't look or feel the way that I thought that it was supposed to, or the way that it should. My boys were really young. I was really struggling with the parenting. I was actually at the physiotherapist's office, and I looked up on the wall and saw an advertisement for something to support both mental health and parenting. And I just felt this final sigh of relief. I wasn't the only one who was suffering. I wasn't the only one who felt lost. And it really gave me the ability to become the parent that I wanted to be. Hi, my name is Ashley Farrison. I'm the peer parent coach manager for the BEAM team, and we are based in Winnipeg at the University of Manitoba at the Children's Hospital Research Institute of Manitoba.
BEAM is a 12-week emotion-focused parenting program delivered virtually through an app. The BEAM program was designed to fill a gap in current services for parents seeking mental health support, because we know that a lot of folks struggle waiting on wait lists, finding affordable mental health care, and navigating the public health systems.
Our goal with BEAM is to have a widely accessible program that uses best practices in digital mental health, combined with the value of community connection to improve family mental health and get families set up on a road to success in caring for themselves.
That's why it was really important to us to offer a service that was as low barrier as possible. So no cost, easily accessible. We offered several different time points for folks to join programming.
We're working with crisis response services. We're working with community organizations and family resource centers, child care centers, pediatrics offices, and primary care offices.
One of the things that really excites me is our plans for adapting it based on the interests and needs of different cultural groups. We'll be working closely with community partners representing Indigenous nations, newcomers and immigrants, and other folks to really meet the needs of those people in that demographic specifically.
Families really face some unique stressors that the general population might not face in terms of their mental health. In the mental health domain, we use emotion-focused therapeutic approaches, which help people understand their emotions and accept the emotional challenges that they're having, while also understanding specific areas that they might want to change. By improving parents' mental health and also improving their confidence and perceived capacity to be caring for their kids and family, we could also provide meaningful improvements to children's mental health. And this is really important to do in the first 5 years of life, because this is a time when children's brains are rapidly developing and the architecture is really being set for lifelong mental health and wellness.
Key components of the BEAM program include weekly short psychoeducational videos on mental health and parenting delivered by expert clinical psychologists. We have guided content review and peer coaching support, one-on-one meetings that participants get to have with a trained parent coach on a bi-weekly basis, where they get to do just a check-in with someone who has the lived experience and knowledge of what they're going through.
A lot of times as a parent coach, parents are sharing things, and I hear constantly, I've never told anyone that before. I've never shared this before. And so we're really cultivating this safe space for parents to share these experiences that they're going through, and to show them that they're not alone. They are also connected to a community, which is also other BEAM participants who are taking the program at the exact same time. The forum is a place where parents are able to connect, where they can support one another, lift each other up, and then also find out about other things that are going on within their local communities.
There's so many social determinants of health that we aren't able to address through this one app, such as needing housing or food security. So we also have an added role in a systems navigator.
They're the connector. They're the bridge to help get someone the services that they need, or at least just some answers, or just pointing someone in the right direction.
There's been an overwhelming excitement and saying, wow, this is really exciting, and we're excited to be sharing this with our families.
It has been really, really wonderful to see the transformations that parents who have already taken the program have seen, the confidence that it's bringing to parents. People have a direction to move towards because they want to feel better. And that's why all parents and caregivers come to us at Beam. They want to feel better, and they need some new tools.
At the heart of the BEAM program is this desire to support families in any way that we can, with the recognition that all families deserve to be really well taken care of.
This is my favorite part of the video, which is that at the end, they just sort of...
5 years ago, parenting...
Oh, no more. Hold on, I'm gonna have to get us off of this. So I almost downloaded some of the videos that I created that where I'm giving the information in Beam to show you that I was there too. They made this promotional video when I was on leave, and so I don't look like I exist except for my picture at the end, but I still thought it was important. I wanted to show you the video and have people talk about it. I'm going to tell you a little bit about the data. First, acknowledging that Megan has her baby here, which is pretty distracting for me and also so wonderful to see. Hi, little baby. And I'm going to talk to you a little bit about what we have going on in terms of what we've done so far. So to get into BEAM, you need to have clinically elevated mental health symptoms. And that means you need to have high levels of depression or anxiety or clinically significant anger. And we've developed BEAM to be transdiagnostic. So it's based on principles of something called the Unified Protocol and also DBT. And the reason that we allow people to come in with any of these elevations is because we find that they all hang together. People who are really anxious often have depression. People who are really depressed are often very angry. And because our focus is on interrupting the intergenerational transmission of stress, we wanted a treatment that could target any of these different things. One of the things that we see in terms of interrupting that intergenerational transmission of stress is that mental health treatment is great, but you have a 50% greater impact on children if you also teach people evidence-based parenting techniques. The reason for that is even if our mental health gets better, if we've been parented in a way, or if we've seen a lot of parenting that caused us to feel depressed or anxious and angry, we might not have the skills, we might not have learned how to not parent in that way. And that's no judgment on people, right? Like people get parented in these ways because their parents have been victims of colonization, or their parents have been hurt by things that psychologists have done, 20 years ago or 30, 40 years ago, saying, don't pick up your kids if they're crying, right? Like we've shared this information. And so we really wanted to empower people to get their mental health back, but also to do the emotion-focused kind of parenting that's going to keep them feeling happy with their kids, liking being with their kids. That's been so important to us, that people feel joy in their parenting. And also that's going to help their kids develop this resilience as they turn into little people. And we've really focused on this conception to age 5 period because we know that there's so much development of brain architecture here. We have had people who identify as, this is the eligibility for our current implementation trial, but we've had people from 6 months postpartum out to 5 years participate in BEAM. And we're currently have a trial in process in perinatal mental health in Winnipeg, which is called BEAM Perinatal, which is for people who are pregnant and postpartum. We've been developing new parenting material for this because parenting when you're in the first 6 months postpartum is like feeding, managing bowel movements, making sure you can get some sleep. So we've developed this, but the idea is that as people's kids grow up and they get into the toddler phase, which is really tricky sometimes, that they have additional parenting supports through us. what we've seen consistently is that BEAM is superior to, we've done waitlist control, we compared to mood mission, and it reduces symptoms of depression, anxiety, anger, and sleep problems in parents. This is all kind of moderated by what symptom people come in with. So if you come in high in depression, BEAM's helpful for depression. If you come in high in anger, BEAM's helpful for anger. If you come in high in anxiety, it's best for anxiety. We don't know why. It seems to be really, really helpful for anxiety. We keep wanting it to be the most helpful for depression, but it's not. And then we see reductions in harsh parenting. So harsh parenting is what happens when you start to feel really overwhelmed with your kiddo. People might start to get brisk with them. Worst case scenarios is people start to yell or hit their kids. We find that this is associated with anger. We do not find that being depressed and anxious makes you scream at your kids. But if that depression and anxiety turns into anger, which is the emotion that we feel when we feel out of control and we're really stressed and we can't cope. This is not something to judge people about, but that feeling of being angry and not knowing what to do can cause people to act in ways towards their kids that they don't want to. I've never had somebody in my trial that says I yelled at my kids and I wanted to. They say like, I'm here because I don't want to yell at my kids. And we see this reduction in harsh parenting, so parent-child conflict and overreactive parenting. So I told you that we had a really bad app to begin with, and now we have a really good app with pretty high user satisfaction, about 6 out of 7 on our user satisfaction ratings, where we have this app-based information, we have professionally developed videos, and a community forum that's moderated by our peer coaches. Then we have a weekly check-in, which is just checking in with people's symptoms and giving them feedback on that. And then a little lesson about how to take care of their own mental health and their kids' mental health. And I think the most important part right now is we have access to a systems navigator. So if people come in and they say, I can't get daycare, I don't know what to do, I'm freaking out, I'm going to lose my job, we can connect them with a social worker. If they say, I don't have any food for the next couple of weeks, like we say, okay, we're going to get you right into social work to figure this out. It doesn't mean we discharge them from BEAM, but it means that they have this additional support. We're an app-supported peer treatment, so we really believe that we need to be working with other mental health professionals, and so we can help make referrals to psychiatry, we can help make referrals to one-on-one therapy. This is really like a key point of the systems navigator, is that we don't believe that we're going to solve everybody's problems and all of them, but we want to be able to help people have this wraparound support. This is version 2.0 of BEAM, which I think I've already told you about, but one of the things that's come out of interactions with our patient advisory group is that people really wanted to not have to jump into a group at the same time every week. We have lots of parents who are single parents. We have people who are supporting their whole family. People, when we were running group, were calling in from their car on their drive to and from work. And so we have really tried to be maximally flexible. So if people come into BEAM and they just want to do the self-guided content and text with our peer coaches, we say that's fine. If they want to do a session every week with a peer coach, we say that's fine. Like if they want to do 15 minutes, we say that's fine. Because what we have found is that when people are reaching out for support, they can't do always the kinds of treatment that they could do if they weren't parents. And we've tried to be really, really flexible about that. Our coaching is like some of the things that people like the most. It's one-on-one peer coaching. So like I said, people can schedule phone calls, Zoom sessions, or just text check-ins. This is a way that we keep in touch with people. If we feel like they're going to drop out, we text them. Like we really are trying to meet people where they're at with the program, which means sometimes chasing people who we know are really depressed and are not going to come in. Like you'll get extra calls from us if you start missing sessions. You're going to get extra love. If you drop out, we're going to say like, come on back. We want you to come back. And if you don't want to come back this time, come on back next time. Like we are not doing the traditional 8 sessions of therapy the way I was trained anymore. We're doing like boots on the ground. We're going to find you and help you be well therapy. Here's our systems navigator who can help you manage unexpected stressors, create broader community connection, and help people get really like needs that are essential for mental health, like getting housing, helping you find help for domestic conflict, helping you find summer camps. Like it's a really wonderful service. We developed BEAM first for people who identified as mothers, but then we kept finding out that people wanted to refer other caregivers to it. So we just opened it up. This is our strategy. So now we have about 87% of people in our implementation trial who identify as women, about 15% who identify as men, and about another like a smaller percent who identify as non-binary. We've been really, really careful to keep our language gender neutral so that when people watch this, they feel like they can connect and be a part of it, no matter kind of what demographic they're coming from, no matter what parenting situation they're in. Like, we really want people to feel like they're welcome in BEAM. This is just to show you that based on our first couple of cohorts of enrollment, we have about 60% of people who identify as white European or Canadian, 25% who are Indigenous, so First Nations, Métis, or First Nations, Métis and white, other combinations, and about 15% of people from other groups. So we have tried to make our videos inclusive. We've really worked with communities, and particularly Indigenous communities, to talk about community care. And Dr. Singla talked about that too. Like, postpartum depression is normal if you're alone trying to raise your kids. Like, that's not how evolution made us raise children. And so much of BEAM is about like trying to connect with your family. Okay, maybe you don't like your mother-in-law that much, but it's still really helpful if she comes over sometimes. So let's figure out how you navigate those conversations. Maybe you're scared to go to the library group because you don't know how to make friends. Totally, I feel that way too sometimes, but let's get out to the library, because when we're gone, you want to have a bigger system of support that's keeping you up. You want to be supporting other people because that's going to make you feel better. And that's like a main part of how we've developed BEAM. And so much of that is in collaboration with our advisory groups, who say that, like, in their cultures, this is how you would raise kids. This is more normal. And I think that's why we've got an arm of BEAM that's called BEAM Indigenous, where we've got people saying, like, come on in, train our people, but we're happy for you to deliver this in our specific community, because it's consistent with this idea that, like, treatment isn't individualistic, treatment's about community care. So there's the BEAM family of programs, which is our emotion-focused mental health and parenting program that's delivered via this online app that I've told you about. So the peer coaching, the parenting and mental health videos, our weekly symptom tracking, access to our systems navigator, and our online group forum. So we've got that now piloting from conception out to about age 5. And just next month, we're launching Light BEAM, which is just a self-directed version of BEAM. It's going to be available to people across Canada. We're going to recruit about 1,000 people, and just deliver the content that we've taken from the app, and then open up our forums. We've done lots of analysis of, like, what parts of BEAM seem to be most helpful for people. And surprisingly, when people use the forum, their mental health seems to get a lot better. Again, this is surprising because our forum is really hard to use in our first versions of the program. Like, it was really clunky, but people who logged in and were interacting with other parents and who were interacting with other peers reported that it was, like, really, really helpful. So in Light BEAM, we're just going to get people access to the videos, and we're also going to let them have access to the forum. And the reason we're doing all of this is because we're going to see this as eventually like stepped care. So who gets better when they just get access to the videos? Who gets better when they just when they also get access to the coaching? Because we're really trying to figure out what's the most cost-effective solution so that we can get resources to the most amount of people. If you're interested in learning more, or maybe you see, like, I would like to do some of the Light BEAM program, again, we'll be launching in like pretty soon, and the website is thebeamprogram.com. We are recruiting for people in BC, Alberta, and Manitoba right now for regular BEAM as well. So if you're like, oh, I think I know somebody who might be interested, definitely feel free to take a gander at our website. And that's all. I want to thank so much our patient partners, the people who've worked with us, all the funders, Research Manitoba, SSHRC, CIHR, the Children's Hospital. We've been so well supported. So thanks so much. And if anybody has any questions, I think I have a couple of minutes to take them, or maybe we're just going to move on.
I think maybe we can leave the questions like to the end. Yeah. But thank you so much, Dr. Tom, for medicine. like I'm amazed at this app, and I find it so amazing that you are like how flexible it is, like decreasing barriers, because we see a lot of times, like at the clinic, we offer groups, but for some patients, it's so hard to commit to like a weekly group, and that 2-hour period, sometimes they have to pick up their children in school, right? Some people have a lot of like more kids, and it's so hard to find that 2-hour period. And also having the system navigator, right? Because I think if someone is going through like housing difficulties, not having access to enough food, there are no CBT skills that is going to be enough, right? And also in terms of the parenting techniques, right? I co-facilitated emotion regulation skills group, and a lot of the patients say that they were raised with parents yelling at them, and then they see that they are repeating that with their children, and they don't want to be that kind of parent, right? So they want to improve and do better, be different. Yeah. Thank you so much. It's amazing. And next, I'd like to introduce Maura. So Maura has been a participant and proponent of mental health support since childhood. Her family suffered a devastating loss with a stillborn daughter, Freya, and they have since welcomed a son, and throughout her journey to motherhood, Maura has navigated many highs and lows with mental health. She is eager to help others by sharing her own experiences. Welcome, Maura.
Hi, everyone. Thank you all for being here today to share in this conversation about women's mental health, especially during the perinatal experience. Myself and my family live in Ontario, but I'm actually joining you today from Invermere, British Columbia. I made the brave, although some people say crazy, decision to visit my longtime friends with my 5-month-old son, Kieran. My partner stayed at home, so it's just the two of us traveling. So with that being said, I will just let you know, they're watching him right now. He's decided to tease the second we got here. So if you hear him fussing, I do apologize for that. So my name is Moira Allen, and I am someone that has experienced mental health struggles since I was a little girl. I began counseling at the age of 11, and I've been in some form of counseling and therapy and working through conquering mental health issues for many years. I'm forever grateful for my mom when I was a kid, who has been an absolutely constant advocate for my mental health. And she always taught me the importance of mental health care as self-care. In that long period of time, I've been a witness to a shift in the mental health care system, as people in the industry have worked so hard to minimize the stigma surrounding women's mental health and the difficulties so often faced by women during pregnancy and after pregnancy. I was so pleased to be asked to speak with you all today, since I believe that there's a long way for us to go still with women's mental health. And as a general rule for anyone, I believe that everyone and anyone can benefit from counseling in therapy at some point in their lives, if not throughout their whole lives. I've always recognized the importance of mental health as an individual, but things really began shifting for myself when I became pregnant with my daughter in 2022. As many of us know, the pregnancy period is so full of anxieties, constant unknowns, and I've always been proactive in the advocacy for my own mental health, as taught by my mom. So when I found out I was pregnant, I immediately referred myself to the Women's Health Concerns Clinic. I just had a fear that my years of anxiety and depression would easily slip into a bout of postpartum depression, and I wanted every possible tool in my tool belt, just to prepare for the worst in the worst case scenario. I wanted to ensure that I was going to provide the best care for my baby, and I knew that meant putting in the work and learning as much as I could do to prepare for this upcoming chapter. What I didn't realize at that time was that the journey that I was about to embark on would look so incredibly different than I had imagined. Unfortunately for myself and my partner, I come from a family with a long history of infant loss. My mother and father lost their daughter, my sister, Heather, due to preeclampsia at 38 weeks in 1982. Earlier still, my grandmother on my father's side lost her son 2 days following his birth in 1950. Um, just the general experiences of those family members is so incredibly different from my own. Uh, it just shows real growth in all of the work that the mental health care system is putting in. Even having the knowledge of all these losses in my family history and being somewhat aware of the potential tragedies of pregnancy and childbirth, I somehow felt untouched by the history and always kind of separated from those things. I'd always worked really hard to protect my own mental health, and I felt that all of the hard work would clearly have visible results. However, in November of 2022, we suffered the loss of our daughter Freya to a complete placental abruption at 38 weeks which was 2 days before her scheduled C-section. Um, the devastation was indescribable, unimaginable. When Freya passed away, so much more was taken from us than I think I could ever kind of put into words. It was all the dreams, all the wishes, the hopes, the fears. I was left in a twist of postpartum grief and depression that was so vast and overwhelming that in the moment, it felt like a room full of black smoke so thick that you could never see an exit sign. Um, Even still, some days I feel that way, but I'm working through the intricacies of the experience every single day. Somehow, possibly miraculously, even in the absolute dark of that time, I was able to recognize that I needed to start the hardest work I would ever do as quickly as possible in order to move through this thing and come out on the other side. I knew that I was at a fork in the road, and I was knowing that I was going to carry the weight of this loss for the rest of my life. And I knew that I could either allow it to break my back for the rest of my life, or I could work hard and learn to accept what had happened so that I could carry it like a stone in my pocket instead. I feel fortunate every day that a social worker with St. Joe's was one of the first people to walk through our door into the room where we were when Freya passed away. My partner and I have so much love and adoration for the work that these people do. It takes a really special kind of person to do the kind of work that this social worker did for us. She was able to guide us with decisions that we never even considered having to consider. She allowed us to cry. She held space for us, all of our pain. She acknowledged that it's okay to feel totally numb. It's okay to laugh or cry or whatever we needed to do in those first moments just to get to the next minute. Um, we trusted her so much that she was the person that we trusted to hold our baby when we left the hospital. But not just her, the entire staff of doctors and nurses at St. Joe's were so gracious and caring. They cried with us. They helped my entire family through this devastation, and I couldn't be more grateful. Since then, I've met with plethora of therapists, counselors, friends, loved ones, um, all to kind of get me through the severe post-traumatic stress disorder that followed Freya's loss. Just the nature in which I lost Freya was so incredibly traumatizing. So there was grief, there was trauma, there was just all the anxieties and all the postpartum stuff mixed into one kind of bottle, I guess you could say. There were sleepless nights, wakeless days, continuous flashbacks, full-blown memory loss, which I still am working through. But aside from that, there was also just the general aftermath, like I was saying, of pregnancy and giving birth. It seemed just a lot to manage at the time. I thank my lucky stars for the Women's Health Concerns Clinic all the time. I've been taken care of in so many ways by this amazing team of people. Sometimes the therapy sessions would be reasonably painless. I would never go so far as to say lighthearted. But other days, the weight of all of the feelings and the realization that my mental health struggles had become an entirely different beast was just so heavy to carry. Being the mother of a stillborn baby is so polarizing. It feels so initially isolating, that you feel as if you may have been the only people to ever go through something like this. I learned recently that in 2022, 3,165 stillborn babies were born in Canada. That is around 8 in every 1,000 babies born. My eyes were opened to the fact that we need to have these conversations. It's so important to speak our truth, even when that truth or experience makes other people uncomfortable. Pregnancy and infant loss is a very common experience that is somehow still seemingly swept under the rug to hide it from any expecting or future mothers. We don't want to scare people. And I don't think realistically it would have made a difference if someone had tried to scare me, but at least we should have the knowledge that these things can happen. We received so much support from the people around us, including a team of doctors and mental health workers, that in 2024, we felt that we were as ready as we could ever be to try for another child. Throughout my entire pregnancy with my son, the anxiety was a wild animal that I sometimes thought just couldn't be tamed. The timing and ferocity with which Freya was born left me feeling like there was no milestone to reach where I could say to myself, okay, we've passed that certain time in this pregnancy, like everything's going to be good now. But luckily, Kieran was born in late August on my sister's birthday, as she requested, to my belly every day. He was born at 36 weeks and 2 days. Thankfully, he came into this world as a lamb, as they say. His birth experience was so calm and soft in contrast to Freya's. He did need to spend 4 days in the NICU because he needed assistance with his lung development and to receive treatment for jaundice, but he was ultimately healthy, happy, and here. The feelings were bigger than I could have imagined at that time. That being said, though, nothing could have prepared me for the mental health journey he was about to join. The road is ever changing, and sometimes it's so overwhelming that it just kind of seems impossible. Being pregnant for a second time was such a whirlwind of emotions of fear and anxiety. It's crazy what the brain can do when you've been hurt. I think it's so important to be transparent about our experiences so that we can relate to each other in an honest way. In preparing, so in the nature of being transparent, I will say in preparing what I wanted to talk about today, I had a much easier time finding what to say about my past experiences with Freya. Figuring out what I wanted to say about my experience with Kieran has been kind of like pulling teeth. I think in a lot of ways, the past is so much easier to discuss because the story's reached sort of a rounded conclusion that you can put together, or as close as we can get. Right now, Kieran is 5 months old. He's very happy, but he's a baby. As you know, they like to scream and be crazy and throw you for a loop when you first feel comfortable in a routine. So I'm in the thick of this experience right now. Other mothers I know have been really forthcoming with words of advice and encouragement. Something my sister said to me sticks with me often, which is that I am currently in the hardest part of the hardest thing that I will ever do. And there's certainly moments when I feel those words so deeply that they keep me kind of putting one foot in front of the other, taking that deep breath to go back and hold the baby and try to calm him. Don't get me wrong, though, having Kieran and graduating from feeling him kick in my belly through his potato stage and now seeing him develop before my eyes with smiles and babbling and all of the other joys that come with those things, it's genuinely been one of the happiest experiences in my life so far. I can hear him giggling in the other room, actually. However, we can hold two truths in our hand at the same time. It's also been one of the heaviest, most stressful, most overwhelming, and most challenging time of my life. The physical fallout from a second pregnancy and C-section has taken a real toll on my body, but also my mental health. From constant like abdominal nerve pain to excessive hair loss to just the changes your body goes through where you kind of don't recognize your physicality anymore. It's taken a toll for sure on my mental health. And there are moments for me when the baby screaming gets to be just way too much, where I'm internally screaming myself or wishing I could literally be any other place than in a dark room trying to rock this baby into some semblance of calm. Um, and let me tell you, this will reach a lot more women than we know. The anxiety from the moment I found out I was pregnant with him was absolutely unmatched, off the charts. Constant spinning thoughts of whether the baby was safe. Is he kicking? Is he moving enough? Am I doing enough kick counts? Was he going to be okay? Was he going to live? That's, for me, that was a big question that I don't know maybe if every mother asks, but for me, it was a huge one. Now that he's here, there's a constant internal monologue of self-doubt and fear. Am I doing the right thing? Is he safe? Is this particular thing going to negatively affect him later in life? Am I talking to him enough? Am I seeing a doctor enough? Is he doing tummy time well? It's never ending. One of the big thoughts too is I should know how to do this. All of this is even before we consider external pressures of social media, other women in our lives, older generations with different mothering tactics, or even just people out and about that you see that you can tell they're looking at you kind of thing. It feels like there's constant judgment all around us. Like, oh, she's carrying her baby like that. Shouldn't she be carrying the baby in a carrier instead of a stroller? Oh, breast is best. You should be swaddling your baby. You shouldn't be swaddling your baby. You should never co-sleep with your child, but your child really needs you to co-sleep with them. Like it seems like every and any question we might have as new mothers has several different answers and an entire team of people behind it saying, this is the only right way. So it can be a lot. In September, I was able to participate in a therapy group through the Women's Health Concerns Clinic for CBT for perinatal experience with Cheryl, actually. I felt so seen in that space working with Cheryl and her staff, as well as other mothers going through very similar fears and nagging thoughts. It was so helpful to learn different techniques for managing all of the big feelings and all the big fears that come with this chapter. We learned thought records, the best friend technique, finding the evidence, and a handful of other methods that to help ground ourselves in reality rather than letting it all kind of float above us in a thundercloud. It's been so incredibly beneficial for me to have those tools in my toolbox. I couldn't have prepared for how much everything in my life and everything about myself would change with motherhood. I thought at the beginning that things would start to mellow out as Kieran got a little bit older and I became more comfortable in the everyday. But it genuinely seems that the new normal is self-doubt, like just not being sure of anything. It's almost like the fading of the person I used to be. So this piece is especially why I was having difficulty formulating what I wanted to talk about today, because before pregnancy, I was so self-assured and I knew who I was at the deepest level. And now in motherhood, it feels like I am still all of those things that I used to be, but there's a whole new aspect of myself that I've never met before, and it's a major, major aspect. I thought I knew what I was getting into since I was around for all three of my sister's sons, and I helped her with them as much as I possibly could. In reality, I had no idea. I had no idea. So I had no clue that motherhood would be so full of self-doubt, so much decision fatigue, so much sleep deprivation, existentialism, constant learning about the next step and what to do for the, baby-led weaning or whatever toddler stages is coming, all the baby proofing, everything has its own manual. And it's just also become kind of stepping back onto the back burner so that my baby can shine. I think for me personally, this trip that I'm on right now, it's been a bit of an eye opener for me in terms of how neglected my self-care has become. I packed absolutely every single thing that I could think for Kieran. I could still probably tell you what the whole list is without even needing to look at it. I know exactly what he's going to need for the amount of time he's away from home. I have the right number of diapers. And the things that I couldn't bring with me, I arranged to make sure I would have them once I got here. But what did I pack for myself? Almost nothing. I couldn't have told you what I needed for an 8-day trip without Googling it. And half of the things that came up when I Googled it didn't make it into the suitcase. So finding time to shower sometimes feels like an impossible task. Getting a quality sleep, never going to happen. Feeling refreshed or energetic without a cup of coffee is something I hope I will get back to. Any appointment on time, super big struggle. Quiet time for myself, what does that mean? And yes, as moms, we must wave our magic wands and make that time for ourselves to take care of ourselves and to treat ourselves to those exact quiet moments or a skincare routine or even just a drive by ourselves to the store. We need to try our best to keep our own cups full because we can't pour tirelessly from an empty cup. We need to put the work in to be able to recognize, listen, and trust our own maternal instinct. And it's okay to look away from the social media posts. So for the perfect mother or the wonderful husbands that do every task related to the baby so that the mom can just relax and put her feet up, not everyone has that situation. And it just seems like a plethora of information out there to make us feel bad about our decisions in mothering. It's okay to know that we're going to make mistakes. Part of the mistakes that matter is how we handle those mistakes going forward. Are we able to overcome these? Are we able to acknowledge and take accountability for the things that we might have done wrong, or maybe that didn't work out as well as we had hoped? And are we going to try again in a different way going forward? It's innately in our nature to make mistakes and to grow and to learn. That's why we're here. And it's so valuable to have a community of people around us to support and uplift us each in our own path. It seems like motherhood to me is a new development of self. In 2022, in the years following, it was so incredibly difficult to understand what it meant to be a mother without. To feel the emptiness in my arms after losing Freya, to just feel that empty feeling in my body that she wasn't there anymore. It took a really long time to understand what that meant. And now I'm learning to understand motherhood in its fullest form. I genuinely couldn't have made it through all of these hurdles without the support of the mental health community in Ontario and across the world, I would guess, and specifically the Women's Health Concerns Clinic. I learned in my early 20s that the key to success with mental health is the recognition that the work is never done, but that you have to go through a lot of trial and error to find what works for you. Not everything is going to work for every person, but the most important factor in all of that is to continue pushing through to look until you find something that resonates with you. To feel whole or to love and take care of yourself, to do the hard work, sometimes the hardest work ever that has to be done. It's so important. You've got to feel every feeling, big or small. You've got to learn to feel comfortable being uncomfortable. You've got to allow or be able to allow other people's discomfort to remain their own. All of these things are possible to work through. Never stop navel gazing. There's always going to be something new to learn about ourselves. Never stop engaging with your community. It's a push and pull. There have been times in my life where I felt that I needed the support so badly from my friends and family and counselors, even strangers, but right now, even in the thick of the madness with my son practically glued to me all of the time, I feel like I've stepped into a different kind of opportunity to help others. I'm hoping that what I've spoken about with you all today has resonated. It's made you feel seen, it's made you feel just a little bit less alone. This stuff is so hard. It's okay to take it day by day, day by day. It's okay to lean on others, and it's 100% okay to need a break. We all deserve the break, and it's what keeps us coming back stronger every time. We are a growth collective, and we can all learn from each other. I am so pleased to have had the privilege to speak to you all today, and I really appreciate it. Thank you.
Wow, Maura, what a story. So thank you so much for your kindness and your courage to share, these deep feelings that you have and you've had all along since you lost Freya. So thank you so much for sharing that. And you also showed us how important, and if I dare to say, how healing it is to be open, to be able to be open to to others about our own struggles. Your story reminded me a lot about number of years ago when I brought the Pregnancy and Infant Loss Network program to the St. Joe's for a training for our staff. And in the middle of the training, I saw myself, sharing my own experience when me and my wife had an early loss in between our two boys, and how healing that was for me, sharing my own experience. And I was always very open about the loss we've had between our two children. So yeah, thank you so much. And if you are questioning about if your story resonated, here I am again, sharing my story, and also, how much that is, it's so nice to see, the support of each other and being compassionate with each other. So thank you so much. And also, I would like to thank you for sharing how you found your own inner strength to deal with the loss. Like, you shared that so clearly, that you found your way to fight and and avoid self isolating and trying to find supports around you. Obviously, we also learned a lot from you today about, I really liked your quote that mental health care is self-care. Like, you showed us how important it is to, look at your own mental health, because it's a really important part of self-care. And it also resonated with me a lot when you said, we're still a long ways to go as far as perinatal mental health is concerned. Like, oh, look at that, how beautiful. Congratulations, beautiful baby. So yeah, I mean, we are here, with 6 amazing speakers talking about really exciting things happening, but it's very important for us to continue, to fight and advocate for perinatal mental health, accessibility, case identification, support, and everything that we can do for this population. I also, it also resonated with me, when you shared about very openly to the audience about things that happen in the postpartum, like the self-doubt, all the sleep deprivation, and the various worries and different worries and anxieties that happen as the babies, grow. It's different worries, different anxieties, pop up, all related to parenthood. And again, the common occurrence of the self-neglect, have all the lists about your baby, but what about your own list? That's always, down in the priority list. So thanks for sharing to the audience the importance of, keeping the self-care up and together. And last but not least, I really want to thank you for also sending a strong word to the audience about self-compassion. I always tell my patients that are struggling that as parents, we can only try to do our best every day. Not every time we're going to succeed. Not everything we do is going to help. Not everything, we're going to make mistakes as parents, even when knowing that we always have the best intentions to our children. So really, self-compassion is really critical part, because parents tend to be feel guilty a lot about things that they either are doing or not, they think they're not doing for their children. So thanks for sharing that, because certainly self-compassion is really important and not easy at times to develop. And also the self-compassion with their own treatment, like understand that sometimes it takes time for people to find their way, right? So we talked about the different modalities, right? So there's medication, there's therapy, there's peer support, there's sleep intervention, lifestyle interventions, and apps and onlines and one-ones, but and the different providers, and it's oftentimes take time for a person to really find what really helps them recovering, and not losing hope is really important. So the peer support and the treatment support and family support is so important. So thank you so much, Murray. It was a really wonderful presentation. All right, so before I introduce the next speaker, we have a couple of things for you. So the first thing is a minute stretch. Okay, so we've been here, for almost 2 hours now. So all bodies will benefit from stretching. So I invite everybody to go up for a stretch, right? So move yourselves, go around, get a glass of water. So we're going to take a minute here to stretch our bodies, and obviously do some self-care here. So we're going to get that. Feel free to go around. We're going to take another minute or a minute and a half for people to maybe have a washroom break, or fill up your water or your coffee, or whatever you are. And then Dr. Green will come back with the results of our poll. So we were able to put together the results of our poll. And then after that, I will be happy to introduce the next speaker of the day. So one more minute and we'll get Dr. Green on the screen. Thank you.
And we'll welcome back Cheryl to share those poll results whenever Cheryl's ready to hop back on.
You bet. Thank you so much, Jane. Yes, for those who are interested and curious about who's tuning in and from where, we have a wide range of people joining us within Ontario here. So Hamilton and area, over to Barrie and Collingwood, and Niagara Falls, but also right across Canada. So we have coast to coast people tuning in from British Columbia and all the way to Nova Scotia. And the one thing that I'm really pleased about is that the benefit of recording this opening up event is that it allows for people who aren't able to be with us right now to review it at a later time. And in fact, just last evening, I was with a individual who got passed along a previous opening up presentation on premenstrual dysphoric disorder, and she let me know just how helpful that was for her to see that recording yesterday. So it is not only the folks who are with us right now, but down the road, even years later, this will be a very useful resource for us to have. Thank you. Back to you, Benicio.
Excellent. Thank you so much, Dr. Green. I certainly share the experience about the importance of this online tools for psychoeducation. That's really been my clinical experience as well. So let's move on, and it's my real pleasure to introduce our next speaker, yet another, internationally renowned professional in the area of perinatal mental health, Dr. Simone Vigot. Dr. Vigot is a professor in the Department of Psychiatry at the Temerity Faculty of Medicine, University of Toronto, and also head of the Department of Psychiatry at Women's College Hospital. Dr. Vigot is a leading expert in perinatal mood disorders and has conducted some of the largest studies worldwide on maternal mental illness around the time of pregnancy. While we know a lot about what treatments work, we also know that as few as 1 in 5 affected people actually get the care that they need in a timely manner. And all speakers pretty much spoke about the issue of accessibility. So the moving is the Pregnancy Postpartum Mental Health Organization Optimization Virtual Intervention Network, which is a newly developed health system intervention designed to close this treatment gap. So Dr. Vigot's presentation will focus on the rationale for the moving project and the early evidence about its impact. So please, Dr. Vigot, thanks so much for being here with us today.
Thank you so much, Dr. Fry. Everyone can hear and see me okay? Yeah?
Yes.
Okay, wonderful. So thank you for such a kind introduction. I'm glad to come and speak here today, and unfortunately, I had to miss the very little part of the morning, but I know for a fact that Dr. Singla talked to you about this as well, and I think it really sounds like the theme throughout the day is really about how do we get the care that people need to people when they need it, and it really resonated with me as well. What Moira was saying, like how do we get people what they need? So that is what Movin' is about, and Movin', there are many people on this slide are part of Movin', and lots and lots of people involved, and probably more will be involved as we go forward. I do have some disclosures. I received some funding from Up to Date, which is a company that publishes kind of like clinical practice help for clinicians. So I get some money for authoring some materials on depression and pregnancy. And some of the research that I'm going to talk with you about today has been funded by the sources in this list. So you've already heard today about 20% of pregnancies are affected by mental health issues around the time of pregnancy. If there are about 400,000 births in Canada every year, that means we're talking about at least 80,000 pregnant and postpartum people and their families in Canada every year. And as you've heard already, this is a really unique time where mental illness doesn't only affect the person themselves who's struggling, but also, it affects their children and their families. So if, while this poses challenges, it also poses really amazing opportunities for, for the health of our populations and the health of generations to come. Untreated or undertreated illness, as you know, really impacts on the function of a person, their sense of well-being, their experience of pregnancy and parenthood. If you don't treat mental health issues around the time of pregnancy, they're not just going to go away. They have the chance of developing into chronic mental health problems, or if they were there prior to the pregnancy, continuing to be mental health, chronic mental health problems. And then untreated and undertreated illness can also directly impact a baby and child development. And while really scary outcomes are really, really rare in our kind of developed country where things like maternal mortality is quite low, actually. Completed suicides are some of the most common reasons why a young mother could die. So this is something where it's really, really essential. There are so many people affected, and it's really, really essential that we make sure that people get what they need. The good news is, as you've heard today, perinatal mental illnesses are highly treatable. So we heard, I think, about psychosocial interventions like peer support, parenting support, even like supportive home visits, where trained nurses go and provide support, increasing supports, in the environment and with the family. When people have slightly more severe symptoms, I think you've heard about today also, psychological counseling treatments are really, really highly effective. And when those don't work, we have other treatments such as medications and other kinds of treatments that can be helpful. The problem is we have a treatment gap. There's really good evidence that very few people, maybe 1 in 5 people who struggle with mental health issues around the time of pregnancy, actually get the care they need to be in remission from whatever their illnesses are. And you've heard a lot today, some of this is maybe not knowing that you have something that can be treated on the part of patients and providers, shame, stigma, I wanted this baby so much. How can I have any negative feelings surrounding that? Practical considerations, like how do I go for therapy every week, for 12 weeks or 16 weeks when I'm pregnant and I'm trying to, get in all my hours before, so that I can get my employment insurance? Or how about, in the postpartum when who knows when the baby's going to sleep, et cetera. Like all of these barriers are there and we've heard them all. But in Canada specifically, and in a lot of other places, another issue is, really long waiting lists for care, and then kind of an unequal distribution of specialized type care, right? If the person who's treating you doesn't really understand what you're going through at that time in life, or, the doctor who's treating you and talking about medications doesn't have experience with, what might be the implications of medication in pregnancy, that could present problems if you can't get into that specialized care. And in a survey that the Canadian Perinatal Mental Health Collaborative, which is or was a major advocacy organization in this area in Canada, they found that 42% of Canadians in their survey were reporting that they were waiting 2 months or more for access to treatment for their perinatal mental health problems. So, you're pregnant, you have a small baby, like we can't be sitting around waiting 2, 3, 4, 5, 6 months the whole pregnancy until you get access to care. So it's interesting in Canada because actually we have a lot of programs in the community that at low or minimal cost offer education about perinatal mental health issues, offer a lot of those psychosocial interventions, which might be what a lot of people only need. We also have individual providers who may have specialized training in psychological therapies, which presents an issue often in Canada because if those people aren't associated with a provincial health service plan, they might not be affordable if you don't have other insurance. And then you might have other people who are specialized in the psychopharmacology or the medications, but maybe can't provide the access to some of the psychosocial or the psychological interventions. There are about 10 of these, specialized perinatal mental health programs across Canada, like the Women's Health Concerns Clinic in Canada, like in Hamilton, like the Reproductive Life Stages program that I work at, where we have a whole bunch of different disciplines, and anyone can come into our clinic and they can receive, pretty much everything from the psychosocial to the psychological to the biological supports, and and follow up, and you can kind of figure out which one they need, and if one's not working, what do you do? The thing is, if you even just take Ontario as an example and you say, okay, well, there's about 140,000 births per year in Ontario, If a fifth, if 20% of those people need perinatal mental health assistance, we're looking at about 28,000 people who need perinatal mental health assistance. If you count up those 5 programs in Ontario, we only collectively serve about 5,000 people. And so the question is, so who gets referred to our clinics, right? Like right now, the way it works is the referrals to the programs might be based on where a person lives, whether their clinician is aware of the program, right? Not necessarily based on whether they need, to actually see, like, let's say a psychiatrist like me who specializes in the pharmacology. Maybe they would have done just fine, with peer support or with something that we could have gotten them more quickly in the community. And this is how all of our services in Canada are kind of arranged. And so, the question in my mind is, we have all the pieces that we need. We kind of know what we're supposed to do. And in fact, we have a lot of those pieces that exist in the country, but how do we close the gap between what we know and what we do? And what would it take for anyone who needs it, essentially, to have access to what they need for perinatal mental health care? And so that's where Move-In came in. And the idea is it's based on an evidence-based care delivery model called, for depression and anxiety, called collaborative mental health care. And the idea is that if you at the forefront have someone called a care coordinator or behavioral health manager who is, who's versed in problem-solving therapies, who can help figure out, what's someone's history, what's the severity of their illness right now, what are their treatment preferences, like where should we get them to first? And if they need does the family doctor need help, managing medications? Could they go to peer support only? And, but what if they need, what if they actually things are more complicated? Can we get them into, a more, like a higher intensity program with, longer term psychotherapy and the psychiatrist? And if we could organize things that way, it may be possible that kind of the 5,000 people who need the really, really comprehensive programs will get to them, and that maybe other people can be served with other aspects of the step of care. And this actually works really, really well. It's been tested lots and lots and lots for depression and anxiety outside of the perinatal period, but it hasn't really been tested so much within the perinatal period. So, we had this idea to say, well, why don't we try and stand up a model and see if we can make this work in the perinatal period, with the idea that it would start patient facing. So it's not like your provider has to identify you and refer you. They can, but you can, as a patient, just, come through the door. And so we designed this platform, and it's actually getting updated for our next trial. It's going to have some new colors because this was designed maybe 4 or 5 years ago, and now when we went back out to our persons with lived experience, that we've now modernized, it has a bit more sharp colors. But anyway, I'm showing you the older platform. And so there's a curated knowledge center where, like, we've put together, there's so much on the internet. So we've put together, various pieces of things that people might want to read. There's a mechanism for people to self-screen for their symptoms and get some feedback on that right away. And then they can connect and plan with this care coordinator to make a treatment plan about where they can go. And a psychiatrist with expertise oversees this, helps them connect with their family doctor, and can see the patient directly if needed. And so this is just a little stand-up of what the knowledge center looked like. It's actually going to be nicer now in its new form. It's for app and web, but basically you can filter by the topic, the language you want, special populations. There's these different filters. And if you when you do your symptoms, if you, let's say I'm having a lot of trouble sleeping, it will automatically sort of flag some sleep articles for you to read if you want to, but you can really read any of the resources. And then you can go in and you can check your symptoms. We use the Edinburgh Postnatal Depression Scale, which is one of the most valid symptom scales for detecting perinatal depression and anxiety. And then it shows your results, and and people can track their results over time, but basically it sort of shows, you have a certain level of symptoms, here's the kinds of treatments that might be good for this, but, would you like to schedule a call with a care coordinator? And then with the care coordinator, they develop a care plan. And that might include additional resources to learn from, community accessible treatment. So the one I'm showing here, is an online group therapy program that we run out of Women's College called Mother Matters. We're actually updating it and changing its name to Postpartum Matters, but I can't remember, I think it was maybe Leanne was saying about how it's really hard to get a certain place at a certain time. So this is an asynchronous group, and it's like a web platform, and people could go in, and it's therapist facilitated, but they can go in any time or day. And then the other piece is, sometimes the family doctor or other primary care clinician needs to get involved, and we can help with that and arranging for psychiatric consultation if needed. And then the other really big thing, which I think I heard from a number of people, and I think you said this, Moira, it's like, if something's not working, then you need to change to something else, and you need to keep going, and you need to figure it out. So within the app, people will get an email or a notification from the app saying, hey, 2 weeks later or 4 weeks later, depending on what they decide with the care coordinator, since you did this last time, how have you been doing? And then, do we need to change something? If you're not doing as well, do we need to change something? Then they meet with the care coordinator again, and they can figure out, did they try to do something and they couldn't get in, or it didn't work, or they did, our whole postpartum matters program, and they're actually just not very much better. What else do they need? So we can continue to do that. And we ran a pilot trial already of this to assess its feasibility and to gather some preliminary efficacy data. And there were a few really interesting things from the pilot. So first of all, we recruited 100 people really fast. And keeping in mind that 50% of them were randomized to sort of a usual care control, where we basically just gave them a bunch of resources and here's where you could go. And so it just speaks to the need for this. For sure, in Ontario, at least, we took people from anywhere in Ontario for this because we have our medical licenses in Ontario, and the way it's organized is jurisdictional. But I was just amazed. I thought, oh my goodness, if we have like 100 people who right away in 2 seconds are, willing to do this, it must just really show, how much need there is out there. And in the move-in group, so there were 48 of them that were randomized to the move-in group, almost all of them logged into the platform. Of the ones who did, all of them completed the follow-ups. So we kept them in. It's not like they just had, one call. They actually completed the one or more follow-ups. Almost all of them had a call with the care coordinator. What I thought was most interesting of all is that only in 2 cases did the move-in psychiatrist had to get on the phone with the primary care provider to help the primary care provider. And only 3 times out of the 48 people did the psychiatrist have to kind of become directly involved. And I was actually floored that at 3 months after someone got into the program, we had a 20% difference in being in remission between move-in and the control. And at 6 months, it was 75% of the people versus 50%. So it's not like nobody got better in the usual care. We do have things, but essentially simply by providing some brief problem-solving therapy, kind of moving people toward what they needed, escalating things if needed. We got 3/4 of the people better. I have to tell you, this is better efficacy results than an antidepressant if it's true, right? This is better than medication. And we didn't even really create any new services. We just reorganized things. So on the basis of that, the Canadian Institute for Health Research has funded us to scale this up and see, could we really stand this up for all of Ontario? And we got the 5 really biggest kind of perinatal specialized programs that have all the specialty stuff to come together in Ontario for this grant and say, okay, so patients can come in patient facing, they'll get the care coordinator, we'll figure out, where they can, what sort of psychosocial and psychological supports they can get in the community. If needed, we'll have a psychiatrist who's overseeing this and can talk to their family doctor. But for the people, those, quote unquote, the 5,000 of the 28,000, can we get the right people into, the really highly specialized resources who need it, and then we could maybe get them in there faster. And I'm really excited about this. Some of the people involved are on this call because what it looks like is going to happen is we're actually going to have a psychiatrist involved from each of those programs who will sort of rotate as being the psychiatrist, who oversee the care coordinator. And if this works, you can see how this could be replicated in other jurisdictions. And, I was listening to Dr. Tom Madsen, like in many ways, BEAM is similar to this too. Like, I think we're all sort of having the same idea, and slightly different things may work in different, in different jurisdictions. But I think it really does sound like a lot of us are just saying, we really need to close this treatment gap between what we know works, and what we're doing. So, this is going to be a big lift. Really grateful to all the people who are coming together to work on it. And I think we're going to be launching, we're just sort of finalizing some of our platform updates. I'm hoping by May will be launched. So just want to close by saying, what you all know, mental illness is common around the time of pregnancy. It affects so many people that we should know that even small improvements that we can make to the care that we're delivering can have a really big public health impact, as well as a personal impact for the health of pregnant and postpartum people and their children. So I will stop there. I hope our idea was clear, and I would be really open to questions or ideas at any point as we are continuing to iterate this intervention. So I will figure out how to stop sharing.
Thank you so much, Dr. Vigo, for an excellent presentation. Of course, it's very important to understand why you're proposing this program, and you elegantly, reiterated a lot of some of the important things that there's a treatment gap. Right, there effective treatments, they do exist, but there's a gap in terms of access. I think you touched on a point that I don't think we talk enough, which is shame and stigma, because a lot of the times people don't reach out to services, in part because of feelings of shame and stigma, and not just self-stigma, but also family stigma and stigma in the environment. So I think I'm a huge proponent of fight everything we can do to fight against stigma. So thanks for raising that important issue. The long wait list, of course, and we don't have enough specialized care for the demand, and you showed the difference, 5,000 versus 28,000. It's a big gap, big difference. So it's wonderful to see the moving coming into life. Congratulations on the pilot, and to me, it shows how having a self-referred, program, low barrier, easy access. I can totally envision that, being so an important way for individuals here in our country to receive care. And Dr. Thompson Madsen also showed us, a lot of the progress with the BEAM, which has indeed a lot of commonalities. I thought this is obviously another wonderful example of a mix of self-guided and guided, online intervention. And we know, the step care approach is one of the effective ways of treating people with perinatal mental health. So I'm really looking forward to the big trial, and so you can show the world how good this program will be. And also the asynchronous group support. Again, I think it's, there's a common theme here across all 6 speakers about peer support and how that is truly important. And I also found it fascinating, the ability to reassess. So this is a program that if something is not going well or not going as, the person and the provider hope, there's a way of, bringing that to life and say, listen, it's time to reassess what else can be done for this particular case here at the personalized level, which is really what's more important. So thank you so much for your presentation, and wonderful to see the work that you and your group are doing, and we here at the Women's Health are obviously thrilled to collaborate in that as well. So it is my pleasure to introduce Megan, our next speaker of the day. Megan is a frontline healthcare professional who is well-versed in the hospital system. Prior to giving birth to her daughter, she and her partner suffered multiple pregnancy losses. Her high-risk pregnancy led to a healthy birth and added to her already present anxiety. At 10 weeks postpartum, her anxiety levels led to visits to ER. Finally, having a diagnosis and receiving support has led to a very positive turnaround. Megan is proud to share her story so that others reduce the shame spiral and feel less isolated. So here, the shame the story coming to life. So welcome, Megan. Thank you so much for being here with us today.
Hi, everyone. Thank you so much for having me. I'm, emotional just hearing that introduction from Dr. Frey because, this has been a journey I've been on for a long time. A lot of the time I didn't know I was on this journey. So coming to fruition and hearing it come out of somebody else's mouth is really reassuring, and recognizing that people hear me and hear the situation that I've been through. So first off, I just want to say thank you to everyone. I want to say thank you for the work and to the presenters today so far that have really truly reflected the need within the community. So all of the programs that were presented today, I could really resonate with, and I could really truly see myself utilizing that system when I was going through what I was going through, and potentially for a future pregnancy. So everybody's really hitting the nail on the head from a community perspective, and from my perspective as somebody who's lived through this, the points of access and lack thereof access, or the timeliness to the care. I could really see that reflected in all of the data so far. I'm kind of glad that I got to go last so I could, see all these programs and really reflect upon them. So thank you guys all so much for all the hard work you're doing in this field. Kind of something that maybe I was oblivious to prior to going through it myself. Even still, being a healthcare worker and working in the front lines, I work in geriatrics. I don't work anywhere. I work on the opposite end, not as close to babies, right? And postpartum. So even being a healthcare worker, some of these services I had no idea we had access to. So even just informing our healthcare workers and how we can continue to preserve this and get the word out to others. I am so thankful to be here and to be able to engage in these types of conversations. It really will help propel these programs. And again, I feel like I'm able to tell my story with confidence, and I feel like it's very healing to engage in these types of conversations. And I have already been able to engage in some of these conversations with Dr. Green and her colleagues. And I'm just so thankful to that. And that's why I'm so happy to just, I hear an opportunity and I'm so happy to talk about it and jump on it. So like Dr. Frey said, I am, he didn't say my age, but I'm a 34-year-old frontline healthcare worker. I am currently 10 months postpartum. My daughter, her name is June, and she is a perfect little angel. She was born via C-section, a scheduled C-section at McMaster Hospital. My journey started long before my kind of postpartum experience. Again, it's something that I've learned since in the care that I've received. But essentially, I'll start from trying to conceive. So trying to conceive, we had 4 recurrent losses prior to my pregnancy with my daughter, June. A couple of them were chemical pregnancies, and one was a missed miscarriage, which I'm sure you all are aware of, but that's where your body still thinks you're pregnant, your body does not expel the baby. So that was quite difficult. With that pregnancy, I was referred to the early loss clinic at St. Joseph's Healthcare Hamilton, which was great to be referred to a service so quickly to care for my need, but it felt very technical at the time. I'd also like to just point out, before going into my story a bit further, that I'm sure many of you will identify at different points through my story where I could have received some support and some mental health support through the perinatal processes. And I don't feel like I receive that all of the time. So it's great hearing all of these services that are available, even such as soon as you find out you're pregnant, going to the Women's Health Concerns Clinic. I was not aware of those services. So when I went to the early loss clinic, it was very technical. It was very much, well, this is only your second loss. The first one doesn't count because it was a chemical. We have no concerns, which is painful, right? And I know we've all heard that it's quite painful to disregard chemical pregnancies and pregnancies like that. So one thing which I'll bring up later in my story as well is sometimes there are processes in place that you don't really understand when you're going through some of these situations. So one of the things that I think is going to be very heartwarming at the end of my story is that while I was at the early pregnancy loss clinic, they had a bowl of wool hearts, and they said, I'm going to give you a minute, pick a wool heart. It's something to remember your baby. This is my little wool heart. And I will kind of conclude where that's brought me at the end of my story. But after that, I engaged with fertility, a fertility clinic within the community because of my multiple losses, and just to check it out, see if there's anything going on as to why. Essentially, they found nothing. There was no good reason as to why I've had multiple losses. Again, a lot of people don't see early loss chemicals as losses, but in my mind, if I was having recurring chemicals, what's going on? Essentially, they couldn't find anything. When I did get pregnant with my daughter, June, I felt as though the fertility clinic was extremely supportive until I got pregnant. So it's like they want to try everything in their power to get you pregnant. Essentially, I didn't need their services. Like, I didn't receive any medication, anything like that. It just happened naturally. But as soon as I got pregnant, I felt dropped by them, right? They're like, great, we got you pregnant. And then I had no mental health support between that period and what the general society tells you of, you can go see your family doctor at 12 weeks, right? And that's a very long time when you've had recurrent losses to not receive any sort of mental health support, especially if you have prior exposure to mental health issues, which I didn't know at the time that I had. So, you know, that goes into months of worrying of, is this going to happen again? We don't get frequent scans, nothing like that, right? Because nobody is there to support that or facilitate that when you've had multiple losses. I wasn't receiving that support. So for 12 weeks, I'm worried sick that, again, I had a miscarriage. So my body isn't even going to tell me if I miscarried. So it's worrying and worrying and worrying for 12 weeks straight. After 12 weeks, I felt a little bit relieved, not fully, but a little bit relieved. And I kind of lived in a fairy tale world until 20 weeks, where I kind of felt like the other foot was going to drop as soon as technology is so good these days that something like an anatomy scan, it's almost like you're always going to find something. So I felt that. I felt like that was going to happen for me. My anatomy scan was scheduled at McMaster University, McMaster Hospital, because my brother was born with a congenital heart condition. So it was recommended that I get my anatomy scan there. Upon receiving my anatomy scan, my daughter had a hypoplastic nasal bone, which is a soft marker for Down syndrome or trisomy 18. I spoke to genetics and they had no concerns about that. But then I had a OB call me and state that baby was measuring very small, and that was a greater concern at the time. So as one fear lifted, another one came in. From there, it was hectic until I would say a couple months ago. Like it was just a whirlwind from there on out, and it feels like a lifetime ago now, but it still does feel very real to me. So it's a very sensitive topic. But from there, essentially, I was told baby's very small. because it's caught so early, we don't know if she's going to make it through the pregnancy. So it was that early information from that first care provider that I saw that stated, I can't tell you that you're going to come out of this with a baby. And that stuck with me for the rest of my pregnancy, which is very unfortunate because the next OB that I saw stated, there are a million things we'll see before baby is, before baby passes, but it really stuck with me through the rest of the pregnancy, increasing my anxiety and putting me in a really terrible place. The benefit is that I was then placed with a high risk OB at the MFM clinic. Similarly, weekly scans, constant monitoring. The issue with this diagnosis is there's no answers. So the only thing that they could say was that the blood flow from placenta to baby wasn't the greatest, but it never got worse. So that still wasn't a hard answer. It was kind of like she could have something genetic, she could have this, she could have that. You really don't know. So it was a waiting game. And the way I dealt with my anxiety through my pregnancy was I just told myself I have to get to the end. I just need to get to the end. And once she's here, everything will be okay. And now learning through my groups that I was referred to, that is not the way to deal with it. Just deferring. So I learned a lot through my postpartum journey, but it was not nice. I was taken off of work because my OB was worried that the stress of everything and the frequent appointments and the weekly appointments, along with bedside nursing, I was a charge nurse at the time, dealing with the stress of all of that, was going to be too much on baby. So she took me off of work immediately. I was not ready to go off. I was not prepared for that. And that's a huge support system for me. I love the work that I do. I love the people that I work with, and that was ripped from me, right? And the thought of a normal pregnancy was ripped from me. So that was very painful. After that, I immediately asked for support. Again, working in the system, I understand who I need to go to for that. I asked to speak with a social worker. I asked to receive support I said, this is McMaster University. This is McMaster Hospital. You guys deal with this all the time. You have sick babies. You have parents who are worried. Who are you going to send me to so that I can get, how do I get these resources? There's got to be parent groups. There's got to be people that I can talk to. And first of all, it took about 3 or 4 weeks for the social worker to even get back to me from the statement that I made, because it was the holidays. And, the pain doesn't stop for the person who's going through that. If anything, it made my holidays horrible, to not have support or talk to people. And the answer I got back when I finally did speak to them was, we don't really have much since COVID. And now thinking about it, I'm like, why wasn't I referred to the Women's Health Concerns Clinic, right? Now that I know that St. Joe's takes on people who are in pregnancy, not just postpartum. So it's those little things that we'll see throughout that could have been a helping factor. So very high stress pregnancy, right to the bitter end. My OB agreed that, first of all, she didn't want to risk a vaginal birth. I agreed. And then she also stated if I really wanted to, I could try, but her threshold would be a lot lower for whisking me off into an emergency C-section. And I was not willing to play that game. I already had too much trauma, in my opinion. So we opted for a scheduled C-section. It was a wonderful experience. I'm so glad we went that route. It was so calm. It was so collected, other than the fact that McMaster is also a teaching hospital, and I had about 50,000 people in my operating room, including the NICU, which was great. It's those supports that I needed to help me through. And she came out perfect. She came out exactly 2 kilograms, which is 4 pounds, 7 ounces. And that's the cutoff at MAC for taking a baby to the NICU. And they said she looks so healthy and she is doing so well, we'll let her stay with you. And it's these little things that I really needed to help heal me from my pregnancy. I was doing so well, she was doing so well. We actually got discharged early compared to a normal C-section discharge, which is like 48 hours. So we got to go home early, which seemed like a blessing. It probably wasn't after going through what I went through with my anxiety, but we got home. That's when the little fears started regarding her health. So keeping her temperature up, keeping her blood sugars up. Is she eating enough? She's so small. I want to make sure she's gaining weight. That little stuff then turned into catastrophic situations. Maybe she has this disease. That's why she's so small, because there wasn't an answer, and there never will be an answer as to why she was so small. So is she going to be okay? Is she really just sick and we don't know it? What if, the what ifs, the constant what if she rolls over in her sleep and because she's so small, she suffocates? Like, it was very much intrusive thoughts, which now learning is very common of me. This is not new to me. It was just exaggerated in my postpartum stage. So at 10 weeks, it hit its peak. It was a lot of health anxiety related to my daughter and her becoming unwell. Some of my symptoms were constant worry, that gut feeling that something's wrong, even though you don't know that something's wrong. Your body is physically telling you that something's wrong, even though there isn't necessarily anything. I actually started to be fearful of going to my daughter, which is very hard at 10 weeks because you're feeding her constantly, you're changing her constantly, she needs you. And I was fearful, like I was avoiding it, not to the point of neglect. My husband was here. I knew I needed to do what I needed to do, but I was so scared to tend to her because I was so scared to be triggered by something that was happening with her, and it would progress into this spiral of health anxiety. So essentially, I was nauseous. It was very hard for me to get out of bed. Something that is very, very vulnerable for me to share, but I will, because I think it's so important for others to hear. One of the thoughts I was having, and a lot of questions I received, do you have any thoughts of self-harm? No. Do you have any thoughts of harming your baby? Because I know that's one of the big things. No, I never had any of those thoughts, but one of the thoughts that I had, and it was a coping mechanism at the time, was the way I got through, it wasn't helpful at all, but the way I thought I could get through some of this was telling myself that in the worst case scenario, if she is very sick and dies, at least I won't be living in this pain anymore. And that, as a mother, and even now I'm so emotional saying that because it's so painful to even have a thought like that. So I'm sharing that because it's so vulnerable and it's so real. And when I saw psychiatry at the Women's Health Clinic, one of the first things they said to me was, it's just a thought. It's not who you are. It's not real, which was so healing for me. But it is still very emotional that that thought even came to my mind. So essentially, it got so bad that I was physically unable to do anything. I was crying. I was shaking. I was so worried sick about my daughter, even though there was nothing wrong with her. I told myself I needed to get help. So I called my family doctor. They got me in that afternoon, which is great. That's a great turnaround time. But in the 3 hours between my appointment and the current time, I said, I can't wait that long. I knew that a family doctor isn't just going to pop me a lorazepam, but the ER might. So, and I was just so in my space that I didn't know what to do. And I didn't think that I could survive if I waited that long. So I said to my husband, I know what I need to do. I know that St. Joe's is a mental health hospital and I need to go there right now. I called my best friend, who happens to be a mental health social worker. And she was like, go, you've got this. It was hard because I work at St. Joe's, and I was fearful that I would see many people that I know. I worked throughout many different departments, but I knew I needed the care. The care was fantastic. I was seen initially per our protocol by Emerge Doc, who then who approved me to be seen by PES, our psychiatric emergency services, whom gave me some lorazepam to help me calm down, and then further directed my care. So I was referred to the women's clinic. They did suggest that I start medication immediately, but something of note, if you've never experienced this, when you're in such an anxious state, the thought of a medication makes you anxious. So I'm like, what am I putting in my body? How am I supposed to make this decision right now? I'm trying to breastfeed. I'm trying to take care of my baby. And now I might be giving this to her through my breast milk. So there's a lot, it is needed, but in that moment, it's a very, very hard decision to come upon. So I ultimately decided not to at the time. I got sent home, and I was talking to my friend again, my best friend, who said, if you need to take that lorazepam one more time, you need to start the medication. And I said, fine. And I pushed through for another week, and it was terrible. I couldn't get out of bed. I was nauseous, even though the fear that I had related to my daughter had been addressed. My body remembered. So I called my family doctor. They started me on the medication. I would say about 2 weeks later, I got into the women's health clinic. I spoke to a psychiatrist. He referred me to my programs, which was a great turnaround time in my opinion, but my programs did not reach out to me for a couple more months. So luckily the medication really supported my need in that time. And I felt like I was able to stabilize. And then I further, engaged in a lot of the programs that I was referred, a peer support program, a NEST program, which the others will be able to, they'll be able to reflect on what the acronym is. It's about nutrition, exercise, like focusing in on those important aspects of the postpartum care. And then the CBT, postnatal anxiety group. And I think it's also prenatal. And there are other people in the group that are pregnant and whatnot. This was my saving grace. My psychiatrist, who I believe works under you, Dr. Frey, he is just a spectacular human, and he really taught me some stuff about myself. I learned that I have general anxiety disorder. So that's life-changing. It wasn't just postpartum. When I started taking medication and learning some of these techniques, I learned, oh my gosh, like I've been living with this for so long and I didn't understand and I didn't know. I always would say, what's wrong with me? Why am I such an irritable person? I'm such a terrible person. When I have kids, I'm going to be just like my mom. I'm going to be so nasty. I'm going to be this, I'm going to be that. And I learned this about myself, and I said to Jane on the phone, life-changing for me, life-changing. And absolutely, I needed that care postpartum, but for my life and for my well-being, it was such a huge benefit and a service to me. Being able to connect with others, it's fantastic. And I can't thank St. Joe's enough for supporting me in that. Dr. Green as well. I know that it wasn't you who hosted my CBT group. It was, I believe, your residents. And same thing with Dr. Frey and his, I'm pretty sure my psychiatrist is a resident, and seeing your guys' work and seeing what you do, I can see how much what you believe is reflected through your residents and the work that you do, because they were so caring and kind and really held us accountable and held me accountable to really work on myself. And I can't say anything more about just being in such a good place with my life now that I've been through this program. So I'll just quickly wrap it up with my little heart that I spoke about. I don't typically believe in this stuff, but this somehow came to me. When my daughter was born, First of all, I would like hold this close to my heart. You know, when I was pregnant, I was like, thank you. Thank you for sending your sibling to me. Like, I really was, you know, very much, if I hadn't have gone through these situations, I wouldn't have my daughter right now. I would not have my June. So I really reflect on that. But when my daughter came out, and still to this day, she has a stork bite. And this is going to make me tear up. I'm sorry. She has a stork bite on her forehead in the exact shape of this heart that I received at the early loss clinic. So it really nails home that, and I am not religious at all, but I always say her siblings sent her to us. And that stork bite on her forehead is a big reflection of that. And it's a journey, and we're where we are today because of all of this. And I still look at her and just say, how am I here? How do I have a kid right now? And she's just so perfect in how to recreate that. And I'm just so happy, and I'm so thankful to the program, and I'm so thankful for being here today. Thank you guys so much.
My goodness, Megan, thank you so very much for sharing your story here today. It is so important, you and the others, Moira, Christine, to hear from you. It's painful, but it's necessary to hear about the lack of resources and supports that that you had when you really needed it. And I think, you know, here's the overall tie where the researchers, the educator clinicians that we have as formal presenters here today as well, they're creating, they're working towards getting our evidence-based therapies that do exist, making that more accessible. And we know we need to do better, and we are trying to do better. And fortunate to have you and others again share their stories this way, so that we know what happens when the support is not there when it needs to be. And just again, very privileged to have my colleagues and I and our team be a part of your treatment team when you needed it. It's difficult to go to that place of your own employment to seek help and care when you need it, and to learn that stigma, as we know, can be such a reality that can stop a person in their tracks for getting the care and the health care that they need. And you push past that. Good for you, so that we could receive you and offer the care that you so much needed. So thank you so much once again, Megan. So happy that you agreed to do this.
Thank you very much, Megan. And it's now time for me to thank, of course, all of the outstanding speakers of our event today. I think I said in the beginning that we had a dream team, and you folks was just unbelievable. So that is the dream team I was talking about. So powerful stories, a lot of sharing, a lot of courage, a lot of hope, and also all of the outstanding professionals also showing, you know, how much Canada is working towards a better perinatal mental health care, not just currently, but also for the future. So thank you all. These are all incredibly, you know, powerful stories. I'm still touched, and you know, it really hits you know, home with me, Megan, when you and Moira and Christine, you all shared when the survival mode clicked in, right? So all of you shared with us a moment where you guys told yourselves, like, I can't stop here, I have to keep going. And this is, I tell my residents and my clinical fellows all the time, we have a privilege of working with a population that, you know, has that survival mode to do that also for their babies, right? So it's a powerful moment in people's lives where they would do everything to be a good parent and do that for their babies as well. So it's really amazing to see and hear your stories. So now we have some times for question and answer from the audience. So like I said in the beginning, feel free to add your questions to the Q&A box. If you go to the Zoom to the bottom part, there's Q&A, you hit there and then you can type your questions. And then me and Dr. Caropreso and Dr. Green are going to alternate here and reading some of the questions to the panel. And then, you know, really any of the 6 panelists can answer this question. I hope this is, you know, going to be like interactive and, you know, please feel free to chime in, anybody. So I'm going to kick off with the first one here. So this is, I'm only going to need read the first name. So Caitlin is asking, are there specific resources within St. Joe's or other health programs associated with women's health clinic that are specific to those living with endometriosis and their experience going through pregnancy? So that's an excellent question.
Well, I know that at McMaster Hospital, they have an endometriosis clinic, but I don't know if there are any resources specific for women with endometriosis and their experience going through pregnancy. I don't know if any of the other panelists have any information about such a resource.
Yeah, we know that endometriosis is part of the, if you remember one of Dr. Singler's slides about the pregnancy-related issues that are risk factors for perinatal mental health problems, certainly we acknowledge endometriosis and other, you know, gynecological factors as, you know, risk factors for, you know, mental health problems in the perinatal period. But I don't know like a specific program or a specific specialist that deals with the interface between mental health and endometriosis, but from a clinical perspective, there are gynecological perspective, there are endometriosis clinics like Dr. Caropreso just said. All right. So another question, and this is a question to you know, Christine, Megan, and Moira. So I would like to hear your perspective about what Doctors Singler, Vigo, and Thompson Madsen presented about this, you know, virtual intervention. So we have a team here that you know, I swear it wasn't pre-planned. Okay, the speakers were free to bring their own, you know, topics. And, you know, coincidentally or not, they all brought like outstanding, you know, interventions that have online interface to improve access, all of them. So if you don't mind giving us your perspective about what the future would look like from your experience as far as, you know, access to these types of both self, but also guided, like a coach guided or you know, coordinator guided services, online services. I think we have both Megan and Christine with their hands up. So Megan, do you mind to go first?
Sure. So I did kind of reflect on this as we were going through the presentation, and I'll admit that initially when my programs were told to me that they were going to be virtual, I was a little disheartened because there's something about that group environment that I'm like, if I can get out of the house, if I can get away from baby for a little bit, like those little pieces I thought were going to be so impactful. But once actually going through the program, I recognized how essential it was to be able to 2 minutes before the session jump on my computer versus having to arrange childcare, having to figure out if I'm still breastfeeding baby, how I'm going to do that, and those types of things. So I really did truly appreciate that it was virtual, and I think it does target our population very well. The programs presented today were just astounding. And I think that if I was aware of those types of programs, such as an app where I can be interactive, the access to care wouldn't feel so far away. So even maybe if we still got referred to the women's health clinic and it takes X, Y, and Z amount of time, I still feel like I can start engaging immediately with a professional to help me through what I'm going through in the moment, because it felt very heavy and I felt like I would never feel normal again. And that feeling sat with me for a while until I was able to engage with somebody who knew what they were talking about.
Appreciate it. Thank you, Megan. Christine, and then Moira.
Yeah, I feel the exact same way as Megan in terms of like I was a little disheartened with my son, everything was in person. This was pre-COVID. Yeah, it just felt like you were able to make real connections because you're in person, but at the same time, after having twins, and that the fact that it took so much effort just to get out of the house. I couldn't do it on my own. So the fact that I was able, like Megan said, jump on last second, turn off my microphone if the kids were screaming, like all those little things that you don't think about, but as a mom, you truly appreciate.
Thank you, Christine, very much. Moira.
Yeah, I think I would echo kind of what both Megan and Christine said. I did find it, so I actually had just finished school as well, on Zoom because of the pandemic. So sorry if you hear my baby crying. I found that the notification that some of the programs I was going to be taking part in was virtual. I did find it worrisome in a way, just because I found with school, I often found myself like not creating proper memories to remember the content and everything. But I did find specifically with the CBT for perinatal anxiety program that I did, the fact that I could literally do that session in my pajamas was amazing. Like Kieran was pretty young then, and it was everything was very fresh. There was constant availability. And again, like my other friends here said, having an app or something like that where you can connect immediately. And also what I did notice about the app that really kind of triggered my brain here in a positive way, was that you can actually track how you're feeling. Because I find too, sometimes when you have your sessions further apart, you forget what was the most upsetting thing that happened last week or 2 weeks ago. So I did like the idea that you could actually probably just keep track of everything that's going on.
Thank you. Thank you very much. So I see the scare at first, but then the actual experience has been, overall very positive, and the accessibility particularly being important. 2/3 of my patients that I've seen in the 2024, I got the numbers, were virtual because of their preference. 1/3 of my patients were in person, so that reflects like the reality. So I think we have time for one more question. Do we have
Oh, Christine?
I was just gonna say, you're also able to broaden your, like, the amount of people you're able to help in terms of, like, I have a sister-in-law in Grimsby who would never drive to Hamilton to get help, and that thought for her was like, oh, like I can't do that. So to know that it's virtual or can be virtual was huge.
Thank you.
Oh, Megan?
Yeah, quickly, just to add one more piece. Additionally, I know that to many others, it sounds very much like, not being able to get out of your pajamas or not being able to brush your hair and stuff like that. That's a mental health red flag. But when you're thinking of it in the context of postpartum moms, that's not a red flag for postpartum moms, right? Like that's very much like, geez, I don't remember the last time I showered, because you have a fresh baby. So I think that that's also a piece of it, that it also kind of makes you feel bad if you're like, oh, I can't get out of my pajamas. So the encouragement from the hospital and other programs to be like, no, chill, you're a fresh mom, we care about you, we care about your mental health, is just as important as getting out of the house.
Wonderful. Thank you.
Thank you.
So last question here, I suppose, just given time. It's coming in from Caitlin. We want, she'd like to know, to each lived experience guest, what was the one takeaway? What stuck with you as the most helpful in pushing you forward in your journey? Yes, Megan, pardon me.
I'll start and try to be quick. Couple of key points here. So my daughter, you know, once you're out of that initial emergency alert mode, you really see how beneficial it is to be in a healthy space for your child and be the mom that you want to be. Second would be the team and the way the programs are designed. Like my CBT group, they held us accountable. There was no option to not do your homework, right? They were like, so Megan, what situation happened for you this week? And I'm like, pardon? Like, I need to share with everybody. They held us accountable to do the work that we needed to do, sometimes when we felt like we couldn't hold ourselves accountable, right? Especially being a new mom, you have so many things that you're taking on in your mind, that they did some of that heavy lifting for us. And the last piece is I trusted myself, and I learned, you know, I try to thank people a lot, especially in healthcare, because it's almost a thankless job, right? And I would reflect to myself and say, who do I need to thank for this? Like, do I go back to the emergency physician and thank her? Do I go back to Dr. Green and thank her? And I actually said to myself at one point, you need to thank yourself, Megan, because you did a lot of this work and you wouldn't be where you are today without doing that. So my motivation came a lot from my daughter and recognizing how these programs are going to benefit me and, again, be life-changing for me.
Amazing. Thank you so much for that reflection, Megan. And how about you, Christine?
Yeah, I feel like a big part of, well, okay, I did a lot of work, obviously, but at the same time, we found a really good medication that worked for me. And as much as I recently have tried to get off of it, because just in terms of, there's just some side effects that I don't love, that it's clearly working because I had to go back on. The mom rage just skyrocketed once I tried to get off. And I feel like what I was told at Women's Health Concern Clinic, that it's okay to be on medication. It's okay to need this. And it doesn't like, it's not because you didn't work hard enough. It's just another piece of the puzzle of helping you get better. And I think that's really still had to resonate with me a little bit. Otherwise, like, I'd feel like I'd want to come off all my meds because I just don't want to be on them. But at the same time, knowing that I'm stable, for that being part of the reason why I'm stable was such a huge push for me to just stay on and keep going for my kids.
Thank you so much.
Can I tag on to that quickly? Because just before Moira goes, I was meant to say this. Jane told me to mention this and I totally forgot. But one of the comments I received from my psychiatrist was, what if we stop thinking about a medication as something you need and that you have to take, and that, oh my goodness, like you're this is your life now, to you deserve to feel good. You deserve to be on medication. You deserve to support yourself in this way.
Yeah.
Thank you for that too, Megan. And Moira here before we wrap up.
So I would say that the most helpful thing that I was told by a lot of different people actually, is that it's okay to sit in the feelings. It's actually, you have to sit in the feelings to get through all of them, really. And that it's just, there's no roadmap. That was a big thing for me, is that there is no roadmap, especially with the grief portion of everything that was happening as well. Like, there's no rules of how we get through it. It's just that we will eventually.
Fantastic. Fantastic, Moira. Thank you so much for that.
Yeah.
All right. Well, I think we're at that time, so I'm going to pass it over to Louisa for some closing thoughts.
So thank you very much, everyone, for joining us today. Thank you for the amazing researchers that are doing this important work to fill these gaps in addressing women's mental health, and in special to our panelists with lived experience. I think it's so powerful when people are vulnerable with one another, because this is something that helps not only ourselves, but by being vulnerable with other people, we allow them to also be vulnerable, right? So, thank you so much for that. And in terms of the more practical aspect, so everyone who registered, will receive a link to a recording of today's event. So be sure to look for that and for the resources that will go along with it. And we also want to show our special appreciation to Shoppers Drug Mart and the Love You campaign, the St. Joseph's Healthcare Foundation, the WHCC Community Advisory Committee, and the Dovetail Community. And pass it on to you, Cheryl.
Okay, yeah, just a final thank you to everybody for joining us here today. And I think that this was just a wonderful success. And yeah, I want to wish you a good rest of your day. Thank you so much for joining us. And thank you to our coordinators, Jane and Emily. So appreciate everything that you've done to bring this event together and make it a success. Thank you.